Good morning, everyone. Sorry for the delay. Can you please take your seats? We will start. Good morning once again. Welcome to the 9th Regional TB Symposium. My name is Alex. I'm the field coordinator for our Zhytomyr project, TB project. I'll be acting as the host for the next 2 days, making sure that we get the most of these days. Before we get started with the official opening session, I would like to begin with some housekeeping. First, I would like to highlight the fire exit. We have the 2 doors that are behind and Milmiglia Cafe. Get started.
Yes, hello. Good morning, dear guests. We welcome you to 9th Regional Eastern Europe Central Asia TB Conference. We hope you settled well. Very short announcement. Besides TB as a global burden, nowadays there is another health issue that seems to be a global burden, but we hope it is safe, about COVID-19, the new coronavirus. Just to let you know that Ukraine is safe, Kiev is safe, you don't need to worry. There is no local transmission of this virus in Ukraine. There is only one reported case that is imported, so all is safe. There is just, for your information, we comply with WHO recommendations, and we recommend as well, in case you experience some infectious, like some symptoms of infectious respiratory disease, being cough, running nose, fever, we would prefer if you stay in your hotel room, regarding safety of others, not to transmit. And yesterday you got an email with contact number, that is my contact number and my colleague. If you need to have any extra information, feel free to call. Then we will direct you to necessary channels where to apply in case you need any health issues. Hope not. Have a healthy stay. Thank you.
Thank you, Hajatur. Now, you should all have received our symposium booklet, which outlines the agenda for the next 2 days. Can I please direct your attention to the testimonies of the patients, which you can find at the back of the booklet, and I'd encourage you to look back on these over the next 2 days, keeping the experiences of the patients in the forefront of our minds. So, having said all of that, I'd like to invite our esteemed guests to open the symposium. We have Cristina Falconi, the head of mission in Ukraine, Dmytro Lufer, Deputy Minister of Health of Ukraine, and Sebastian Spencer, MSF Medical Director in Brussels. And finally, we'll have a video from World Health Organization to watch. Thereafter, Yulia Chorna from the TB Europe Coalition will lead the plenary session looking at the latest trends in the fight against TB. Welcome.
Dobre rano, distinguished guests and colleagues. It's my pleasure to welcome you to the 9th Regional TB Symposium, this year for the first time in Kiev. Over the last 9 years, this event has become a prominent date in a diary of the key TB stakeholders, both in the region and globally. It signifies an important moment to discuss our shared success and challenge in fighting the world's deadliest infection disease. This year, the symposium will focus on the theme of transforming policy to practice. Political commitment need to be translated in more resource and implementation. Substantial steps need to be taken to make sure that all the patients can access to the most effective model of care and receive the latest treatment. I invite all of you to engage with this issue, to think critically, and to challenge one another over the next 2 days. And now, it's my pleasure to give the floor to the Deputy Minister of Health, Mr. Luffer, for his speech. Thank you very much.
Welcome everyone. I'm glad to welcome every one of you at the 9th Regional TB Symposium organized by the Minister of Health of Ukraine jointly with the MSF. The fact that it happens currently in Ukraine, in Kiev, is both good and bad. Bad is that we do have a challenge like that in our country that we face, but good is we are coping with that, we are managing that with the support of international partners and Ukrainian colleagues, Ukrainian doctors in Ukraine. I think this is a good sign of our commitment really to overcome tuberculosis. In Ukraine, TB control is one of the priorities for public health and healthcare system development policies. In 2016, Ukraine became, for the first time, top 5 country, one of the top 5 countries with the highest TB burdens. As of today, we see the insufficiencies that we still have in terms of TB treatment, and we have high mortality rates. We also always have issues associated with TB programs funding. We do apply efforts which are still insufficient, and we definitely need to strengthen our activities in this scope. You might know that we are currently reforming the healthcare system in Ukraine, and we plan to have the system in which every TB patient could be able to obtain proper, adequate treatment without unnecessary hospitalization. We engage the primary healthcare level into TB patients' treatment, as well as social workers and social services to that. Just recently, we have adopted the national strategy for TB care development for 2020-2023. This will enable us to initiate the structural reform of TB services. We plan to combine preventive, therapeutic and resocialization programs at the national level. We cooperate with the MSF to implement innovative approaches to diagnostics and treatment of TB, as well as testing them and piloting them. In Zhytomyr, for example, we piloted the patient-centered approach, adapting medical and social requests to make sure that everyone gets what he needs. We do hope that this symposium will provide us with the proper perspectives of further implementation of similar models, not only in Ukraine but also in Eastern Europe and Central Asia. The Minister of Health keeps expanding opportunities for treatment for RRTB patients. We keep procuring approved TB treatment drugs according to the international guidelines. This year, due to tight cooperation of the Minister of Health and other NGOs and public organizations, the first batches of Delamanid have been procured and delivered to Ukraine. Currently, this drug has been procured via decentralized procurement approaches and now is available to every patient in Ukraine. This is actually the embodiment of the new approaches necessary so much to overcome the TB issue. We would like to congratulate everyone who has overcome TB, who has been treating TB, all the key players who need to cooperate at the local, regional and international levels. We do hope that everyone will really benefit from this realistic opportunity for cooperation on the way to the successful and bright future without TB.
Symposium. That's already a success story, thanks to all of you. first organized in 2011, we are pleased to be holding the symposium in Kiev this year. And I want to express my gratitude to the Ministry of Health of Ukraine for their support in co-hosting this symposium. I also want to thank all the representatives of the TB community, including a patient from our Zhytomyr project, for being here over these 2 days. Your experiences, your ideas, your opinions are fundamental to our reflection. Your strong participation at this symposium reaffirms our commitment to put people at the center of TB care. Over the last decade, much has been achieved to counter the TB epidemic, including in Eastern Europe and Central Asia. The most up-to-date global guidelines and protocols have been adopted across the region, and new tools have become available, such as the latest TB drugs and new technologies to support TB treatment. However, there are still gaps in availability, and implementation of these tools has been too slow. We still fail to find, diagnose, and cure many people with tuberculosis. In fact, we have seen increases in the incidence and mortality of tuberculosis globally. And treatment outcomes in this region are still far from reaching global targets. Every day in Eastern Europe and Central Asia, over 50 people die because of tuberculosis, and 20% of them co-infected with HIV. What's more, we are witnessing increasing international fatigue when it comes to funding for tuberculosis. The advances made in tackling these diseases are under threat. Not progressing means losing ground. The world should not allow this to happen. Alongside governments, communities, and all our partners, we have been at the forefront of the fight against TB and HIV in this region for several decades. And overcoming TB and HIV will remain a priority for MSF in the future. Our approach to TB care incorporates greater patient responsibility and decentralized models of care, access to new drugs and shorter treatment regimen, improved patient support, and the destigmatization of people with tuberculosis. You will hear more about how we are putting these into practice across the next 2 days. And I urge you to consider how such approaches could pave the way forward elsewhere in Eastern Europe and Central Asia. With these new tools and approaches, we have a real opportunity to defeat tuberculosis and bring hope to patients and communities. However, ultimately, the responsibility for ensuring access to patient-friendly, effective tuberculosis treatment rests with each country. This requires determination to transform commitment into action, policy into practice. From removing bureaucratic barriers which prevent access to tuberculosis care to improving coordination for the treatment of comorbidities. There is a lot of work ahead of us. Yesterday, I had the opportunity to visit the Zhytomyr project with a large group of delegates. A strong partnership is key to success. Thanks to our MOH partner for going the extra mile in this project. We at MSF will continue to support our national partners to make sure that there is a future where patients do not have to suffer from tuberculosis and the associated stigma, while new approaches and effective treatment options are available. We look forward to hearing more about how we can collectively achieve this over the next 2 days. The very open and honest attitude of delegates during the previous editions of this symposium allowed for a genuine dialogue. A dialogue leading to identification of true solutions. I wish you a great symposium, a symposium that will bring the changes you want to see in the fight against tuberculosis. Thanks.
Yeah, thank you very much for the welcoming speech. Can I invite Yulia Chorna from TB Europe Coalition? She will lead the plenary session looking at the latest trends in the fight against TB.
Good morning, everyone. Dear organizers, dear guests, it's a great honor for me to greet you all in this warm and springy and sunny Kyiv. And also, it's a great honor for me to have an opportunity to make an intervention in the opening plenary session. I come from the civil society. I work in the TB Europe Coalition, which is a civil society network active across WHO European region. And for me, speaking today is really a sign of what a meaningful engagement of civil society highlighted in many policies means in practice. And in the spirit, from policy to practice, set by the symposium theme, let me bring us back in September 2018, time when the political commitments to end TB by 2030 were taken by the member states at the first ever UN high-level meeting on tuberculosis. Let us reflect how far we progressed so far, what we did good, and what we should do differently. Okay. So here on the slides, just to remind ourselves, we see the elements of political declaration. We see the critical commitments. In addition to the targets set by the WHO and TB strategy, Stop TB Partnership Global Plan to End TB. The political declaration resulted from UN high-level meeting on tuberculosis, included new global targets for the period 2018-2022, which should scale up TB response in order to end tuberculosis by 2030. New global targets include treating 40 million people for TB disease, reaching at least 30 million people with TB preventive treatment for latent TB infection, mobilizing $13 billion and at least $2 billion for TB research and $30 billion to universal access for TB diagnostic, treatment, and care. And also, there are commitments which are not really linked to the numbers, but they are critically important. This is a commitment to promote and support end to stigma and all forms of discrimination, to promote and support human rights, to promote and support equity, to ensure that the care available for TB patients are people-centered, convenient for them, cost-effective, and also which takes into account not only medical, but also social and psychological needs. Global TB Report 2019 states the WHO European region is on track to achieve 2020 milestones for reduction of deaths and TB incidence rates. The WHO European region has the fastest decrease in people with newly diagnosed tuberculosis and mortality from tuberculosis. However, we still have an increase in TB-HIV co-infection and drug-resistant tuberculosis. This is actually a public threat for all our regions. It's probably, as you see in the slides, I adopted it from the presentation of WHO Europe colleagues from the joint program of TB, HIV, and viral hepatitis. You see the statistics, and we also see that in the world, till now, every 2 minutes, one person is diagnosed with tuberculosis, and every 20 minutes, one person dies of TB. This is unacceptable. And this is really should make us feel an urge to do things differently and to scale up the response. Well, what we could do to accelerate TB response? What dimensions beyond epidemiological statistics are critical to consider and address? Political declaration of the UN high-level meeting on TB calls for more effective and need-oriented response on how people who are marginalized, people who are socially excluded, and have increased exposure to TB access quality TB care and support services. Global action to deliver on commitments has a strong support by WHO Director General Dr. Tedros, who has written back in 2019 to heads of states in 48 high TB burden countries, urging to meet new targets highlighted by political declaration. Director General activities are also supported by the Civil Society Task Force, which is set by the Global TB Program at WHO. This is another yet example of a meaningful engagement of civil society. However, when we think about translating global targets into national one, should we think how really well we progressed in our countries in order to ensure the official translation of the targets? In the next 3 years, access to TB care and preventive treatment need to expand. Annual financing for TB prevention and care and for TB research need to approximately double. But how we translate the global targets? Here on the slides, you see the reference and the link to Stop TB Partnership tool for indicative targets, which really help countries to think on their share to the global response. These targets are not taken just like separately out of the sky. This is everything which is coordinated and also addressed in Dr. Tedros' communique to the heads of states. So what should we do to formally adopt the national targets? And how we could proceed to reflect them in national strategic plans on TB, on national plans on TB, HIV, and viral hepatitis, on other policy documents, on funding requests, which are now countries going on submitting to the Global Fund. I think if there are good examples from the countries in the room, we have 2 years, or we have 2 days of interaction, and I encourage all the partners to share these examples and share the successes if there are progress in adopting the national targets. With this slide, I just want to highlight that multi-sectoral action on the broader determinants of TB epidemics is needed beyond healthcare sector, as well as collaboration across 3 diseases for health system strengthening. And this response should also be intensified. Here on the slide, you see 3 policy papers. UN Common Position paper sets a ground for multi-sectoral response in the direction of 3 diseases. Tuberculosis Action Plan for WHO European Region 2016-2020 is now there is a task force for WHO Euro region, which is now working on revision on monitoring framework for follow-up on the plan and setting the new targets, which are also more in line with the political declaration, and also multi-sectoral accountability framework to accelerate progress to end tuberculosis by 2030, which was set by WHO, and countries are to adopt this at the national level. As for the practical set of tools, I would like once again to highlight community rights and gender assessment tool, which are presented here on the slide, because this is just a great way to deliver on commitments of political declaration, which are related to ending stigma, to promote the human rights, and to ensure the equity of TB response. This is very critical tools to ensure that the barriers are known to people who are making decisions, and that there is a right response at the country level to remove those barriers. Once again, I would encourage countries to adopt the tools for the regular implementation and the regular response, including through the request to the Global Fund, which are now open. So we are now facing quite a sense of urgency to put in practice the policies and commitments. Here in the slide you see the time frame. 2020 is a UN Secretary General report is due. It will be presented in September at the, at the UN level. And this report it was also something which was reflected in the political declaration. We already have to demonstrate progress and to showcase that we are taking this political declaration into practice. 2022 is a critical year for meeting the targets which I already presented. And 2023 is a UN review meeting which would include also a section of TB progress. That said, I am urging to collaborate further, collaborate with the civil society, with affected communities, because governments alone would not be able to do the response by themselves. We should all do it together because we are all at stake and it's a general commitment. So, returning to multi-sectoral accountability framework, here I would like to highlight some important dimensions which need to be done in the countries right now in order to move to the progress of their implementation of the political commitments. If not done yet, it's a high time to adopt multi-sectoral accountability framework at the country level. Consultation, because it's a WHO document, the multi-sectoral accountability framework, but it's just very flexible. Countries are free to adopt it, but it needs to be in consultation with civil society as well. Second, to formally agree on country targets for prevention, treatment, drug-resistant tuberculosis, children, and other priorities set in political declaration. To involve civil society and TB-affected communities in the development of the 2020 National TB Report, and ensure high-level multi-sectoral leadership over the accountability process. And also, it's a time already to start thinking and getting ready how to ensure participatory approach for 2023 UN Progress Review and meeting. My previous slide addressed the how dimension, and this is actually the what dimensions, and the priority areas to accelerate TB response. We all know that we need to do more to strengthen health and community systems for active finding of people with tuberculosis, early diagnostics, and improve quality of TB care. There is no simple solution, but there are some directions and there are some calls to actions I would want to voice up. First of all, people-centered care, including standardized supportive care services integrated with a broader health system, is a must. I see the colleagues here from the Eastern Europe and Central Asia, and there are some great examples of countries moving to people-centered ambulatory care. There are colleagues from Armenia, and many of you know that Armenia is a champion country in decreasing of unnecessary hospitalization and treatment of tuberculosis at ambulatory level. There are colleagues from Belarus who did a good job with the so-called breast pilot project, which really showed how the money saved on the decreased hospitalization could be redirected to ambulatory people-centered care. And there are many other examples throughout the regions. I think it's very important not to give up, to support the reform, to ensure that ambulatory care is in place as the one which is most convenient, which is most effective for the patients and also for the health system, for the whole health system. Another call is accelerated transition to the new WHO recommendation, including all oral treatment regimen for drug-resistant tuberculosis. 11 countries of Eastern Europe and Central Asia are starting operational research on the introduction of all oral shorter bidequilin containing regimen. This is also a critical development which requires collaboration with the civil society for informed consent promotion, for patient educations, and for support from the treatment. But it's also very welcome development. On another note, with access to new medicines, it's also very important to think about global fund transition and to think how to ensure the quality and affordable medicines even when the donors are leaving the countries. How still to ensure the WHO pre-qualifications and global drug facility preferred and lower prices. This is also something we need to reflect and think and not to forget in the transition. And last but not least, again, meaningful engagement of civil society and TB-affected communities, which helps to removing human rights barriers, ending stigma, and support key and vulnerable people with TB taking an active part in TB response, not only being the patients, but also being the agents of change. It is critical. We know that our region is still have more than 20% of people missed by healthcare system annually, missed or underreported. And also, and I think only with the civil society, so when there's a bridge between the hard-to-reach population, people who are in need, and the healthier system, we could do a difference, and we could do together. It's very soon, it's a World TB Day, with the topic again, it's time. So it's time for us to do better, it's time for us to collaborate more, and it's time for us to progress for ending TB. Thank you for your attention.
Now, before we get started with the first session, we have a video from the World Health Organization to watch.
Dear participants of the 9th Tuberculosis Symposium for Eastern Europe and Central Asia, on behalf of the WHO Regional Office for Europe, I would like to greet you and acknowledge the joint efforts of all member states, partners, donor organizations, and the civil society in combating TB and drug-resistant TB in the WHO European region. Over the past years, the progress was impressive of our joint efforts to combat TB, with an average decline in the TB incidence of 5% and TB mortality 10% between 2014 and 2018, indicating that overall our region is on the right track in its efforts to contain the TB epidemic. But despite the notable progress achieved in the fight against TB in the region, drug-resistant TB still poses a public health threat in a lot of countries, especially in Eastern Europe and Central Asia, which is for me the geopolitical priority. We have 77,000 new cases of MDR-TB in the region, which represents about 16% of the global burden of MDR-TB. The proportion of MDR-TB among new and previously treated TB cases almost 6 times exceeds the global average, and treatment success for MDR-TB remains low, 57.4%. The other serious challenge is the rise of HIV and its co-infection with TB, which is relevant to Eastern Europe and Central Asia. The WHO Europe makes sure to address all these challenges and work closely with every member state, partner organizations, civil society, and communities. We are supporting the development and introduction of innovation and tools such as digital technologies, rapid molecular diagnosis of TB, new drugs and regimens for DRTB, and new vaccines. We are making sure that all people affected by TB have equal access to the benefits of latest development, including vulnerable populations such as prisoners, migrants, socially marginalized children, and people living with HIV. I am very thankful to Médecins Sans Frontières as one of the leading partner organizations of the WHO in our region, the organization that is always available to provide immediate response in the most challenging circumstances on Earth and bring the best quality care to those people in desperate need, bringing innovations and new methods of TB diagnosis and new medicines and treatment regimens for DRTB live into practice, showing the best examples of care that provide a solid background for further scale-up. The WHO is very happy to collaborate with MSF, other partners, donors, communities, civil society, and everyone to implement the joint response to the TB epidemic through sustainable development approach. A very good example of our collaboration and joint efforts is the Regional Collaborating Committee on TB, HIV and viral hepatitis, which is an excellent platform for interactive exchange of information and strengthened involvement of national and international partners to address 3 diseases. I have called my vision for health across the region United Action for Better Health. United because partnership is for me an ethical duty, and action because during my campaign, countries stressed time and again that for WHO it is high time to move from the what to the how, exchanging practical knowledge to solve real problems. MSF in particular is very close to my heart. I started my overseas career with Médecins Sans Frontières, establishing the TB control program in Kismayo in Somalia during the civil war, then being a clinical doctor with MSF during the war in Liberia, after that establishing the TB control program for 2 years in the prisons in Siberia, and then moving to Moscow as the MSF International TB Advisor for the former Soviet Union. As we say, first love never dies. I really wish you all a very fruitful conference with practical outcomes. And I'm also very appreciative to Jarno Habicht, the WHO representative in Ukraine, and his committed team for a strong collaboration in the fight against TB and HIV. Good luck to all of you, and rest assured of my strong commitment for a further collaboration in order to have a Europe and a world closer to being free of tuberculosis and ensuring no one is left behind. Thank you very much and good luck.
That was a good speech. We'll start with our first session. We'll be looking at how we can turn policy into practice. As we have already heard in recent years, many important new tools have been developed, and safer TB drugs and all oral regimens. Many countries in this region are including this innovation in their policies and even leading the way in research. But this often has stalled at the trial or pilot stages. They haven't yet been replicated or scaled up by the national partners. This session will be chaired by Dmitry Donchuk, TB advisor for MSF in Southern Africa Medical Unit, and Yana Terleva, the head of the National TB program in Ukraine.
Спасибо, Алекс. Доброе утро всем. Я думаю, что мы очень хорошо.
Thank you, Alex. Good morning, everyone. And I think that despite we were a little bit late, we still start on time. I would like to thank everyone who managed to come here despite all the difficulties which we're facing now. Secondly, I would like to thank everyone for their welcome speeches, for energizing our symposium. I mean, the WHO and Sebastian and the Deputy Minister. It's really important that we start our symposium on such an optimistic note. Now, the first session is dedicated to how we see and what are the new developments and the new policies in TB control, and how can we bring this closer to the patient. Actually, we have new treatment regimens, we have new drugs, and we start treating patients with shorter all-oral treatment regimens. And this is a huge. These are huge steps in TB control over the past decade. This is the good news. The question is, if all the patients we see and who are subject to treatment, if all of them receive these drugs and these regimens. Unfortunately, a lot of such initiatives remain at the pilot stage, and I would like you, during this morning session, which will last till lunch with a short coffee break, we will have time for reports, for presentations, and for discussions. I would like us to discuss the barriers, the challenges we have on our way to introduce the new and progressive diagnostics and treatment methods. The first presenter is Dr. Yana Terleva. She is the head of the National TB program in the Center for Public Health of Ukraine. And Yana is working in has been working in TB control for over 15 years. She started her career as a TB doctor in a hospital, and then starting in 2012, she has been working as a consultant and as the manager in the Ukrainian Center for Socially Important Diseases Control. Now it is called Public Health Center. Dr. Yana?
Good morning, dear colleagues. It is a pleasure to welcome you in Ukraine, and we are very happy that it is our country that is providing the space for all of us to change opinions, best practices, and to discuss the barriers and the ways to overcome them, which prevent us from the eradication of TB. And we are happy to share our experience and our failures, honestly, so that we all could learn on these, so that we all could learn from these lessons to improve the programs in our countries. We understand the responsibility that our country is facing, because the country is kind of big, and we are now in top 20 countries with the highest burden of the multi-resistant TB, and top 5 countries in XDR. And of course we understand that the Ukraine's progress in this regard will outline the general progress in all the European region. Yes, we note certain successes in the national program. We have the reduction of incidence and mortality, 8 to 10% every year. And if in the previous years we have said that we seem to have a stable situation with MDR-TB, we were very cautious saying that, but this year, for the first time, we also very cautiously saying that we have a reduction in burden of MDR-TB. The data from 2019 shows that we have 6.5% reduction. But we still see that we have a big gap between the estimates of the WHO and the actual data on the identification of patients, both among resistant MDR, XDR, and the co-infected with HIV, and also among children. So the country, as of today, the government is supporting the national program, and at the end of last year, they have approved a strategic document that has been mentioned already by the Deputy Minister today, the strategy to overcome 3 infections, HIV, TB, and viral hepatitis. And this is the vector for all the national policies in overcoming these diseases for 10 years period. It has been developed on the basis of international strategic documents, which include sustainable development goals, the goals of the political declaration adopted at the General Assembly of the UN, and the documents, the guidelines of the WHO. Another document that was developed to implement the strategy is some step-by-step flexible strategic plans, 3-year plans, and now we have finalized another version of this plan. So this plan means a list of activities with specific indicators and targets that would help us monitor and evaluate the progress which we want to achieve in the country. So the National Strategic Plan has also some 3-year flexible budgets allocated for these strategic plans. And now this helps us to be more flexible. When the WHO guidelines might change, we might be faster in adapting our programs. So the main goals that we have set, they are kind of similar for most of our countries. Strengthening the system of TB care, the implementation of effective tools to find our patients, especially for hard-to-reach among hard-to-reach population, and of course the improvement in the quality and effectiveness of treatment for the patients. In our program, today we are using more and more the approaches which we have received as part of the operational studies, and we shorten the gap between the academic research and its application. Here are the main barriers for the national program is trying to overcome. Some of them require systemic change. Some of them should include measures at the level of some specific TB clinics. Also, we have identified the gaps in communication among the doctors and patients, and the individual barriers that prevent us from achieving higher or better success in treatment. So these are the 6 directions where we will work intensively. Of course, the WHO, in its key announcement, has set some very ambitious goals for countries to substitute sputum microscopy with gene expert. That's quite ambitious. So in our country, unfortunately, we have to state that from the moment when TB systems appear and the patients starting treatment, it takes months. So if we only procure these new testing systems, we wouldn't be able to overcome this barrier. We need to improve the system of logistics for sample transportation, patient referral, staff training to ensure sustainability of this at the national level. Of course, in order to properly use resources, we also have to ensure the system is effective, because our system is still too redundant. The inpatient stage is prevailing over outpatient, and well, maybe some of the reasons were that up until recently we didn't have financial tools that would help us transform the system. At the end of last year, the government has approved the strategy for TB service reform, and we have now a goal. Within 3-year period, to bring our TB program in line with the current guidelines, to bring the number of beds in line with the WHO recommendations, and to make sure that the patients receive patient-oriented care. And from this year, the 1st of April, we start the reform of secondary and tertiary care. We have new financial tools introduced. We have high expectations that these targets are achievable as part of the general reform. And then we'll have clear delineation of roles and responsibilities between different levels of providing care. At the level of primary care, we will provide most of the services our patients are requiring, and will reduce the barriers for accessing care. Of course, reforming the system without some specific system to capture the data, the electronic system, that wouldn't be possible. At previous meetings, we have presented our tool called eTB Manager for all patients with TB. As of today, it has 410,000 TB cases in the database, and over 3,000 colleagues are using the database. And this year, we set a task to integrate the eTB Manager and HIV MIS and the general e-health system. This merge would help us to manage the data timelier. And we are now undergoing this process of merge. The next stage, of course, would be access to new drugs. Unfortunately, in 2017, we had the possibility to only get 200 patients on bedaquiline. Last year, it was a breakthrough, and 10 regions have got full access to bedaquiline and dolamamide. And basically from June, we had a full-scale implementation of bedaquiline in all the regions of our country. And today we can say that over 3,000 cases receive this new drug. And from February, all have access to Ndlamamide. And we are not stopping. So as the first step and as the country's intent to implement new modern countries, the new drug Ndlamamide will also be procured with the budget funds. Also, we support the proposal of the WHO. The WHO proposed to join the trial of new short regimens, and we have identified 15 sites that will implement this operational study. So by the end of the year, we will recruit at least 1,000 patients, and we have even more ambitious scale-up goals for the next year. And of course, we have been saying that at the moment the efforts that are applied, they have to be generalized and lessons have to be drawn out. And we all have to work so that the strategies which we develop would really be oriented at our patients and their families. And for these, the crucial role is played by the partnership which we have. And MSF is one of these partners, a very reliable partner that helps us improve our system, learn the best practices, and just improve the quality of care for the patients. I wish you a lovely time in our country. I hope this sunny weather will give you a lot of good mood, and this event will give you a lot of useful information that you'll later implement in the countries. Thank you. Thank you. After this session the sessions will be over, we will have 1 hour for general discussions and quick Q&A. So unless you have a very urgent and specific technical question, we'll leave the questions for later. Now we'll move on to the next presenter, Dr. Fuad Mirzaev. He works in the WHO in the TB control department with Stop TB from 2004, and he has a lot of experience with MDR TB, also in the Green Light Committee and within the WHO, and he is a frequent visitor in our symposium, so I'm happy to give the floor to Dr. Mirzaev. Thank you. I would like to say thanks to the organizers for this invitation. I'm happy to participate here, and it's great that we have a full room here, regardless of all the issues that are happening globally now.
Will be in English. So I'll be talking about in this next 10 minutes about the WHO consolidated guidelines on drug-resistant TB, and just a little bit on the updates, as much as I can tell you about what's coming up. Before doing so, I would just want to put this slide on the screen to make sure that we kind of refresh in our mind the picture and the situation that we are trying to deal with, which is MDR TB and rifampicin-resistant TB in the world, according to the latest statistics that were presented in the Global TB report released by WHO last year. So, yeah, it is a major problem. About 500,000 cases estimated in the world. Unfortunately, only a small proportion of them are being notified. About close to 200,000 and slightly even less patients are being put on treatment. The situation is much worse with so-called XDR TB, extensive drug-resistant TB. Even the smaller number of cases are being notified and enrolled. And what is worse, that the successful treatment outcomes are quite low for both MDR TB and extensive drug-resistant tuberculosis. So to try and help to deal with this problem globally and help countries and partners to have the most updated knowledge and experience, WHO have been releasing regularly its guidance on treatment and management of drug-resistant TB. Basically, starting back in 95, 96, where the first guidelines have been released, Those times they were mostly based on the experience and expert opinion. The situation has started to change in 2006 and 2007, where WHO has switched to evidence-based guidelines. So since then, all the guidelines have been developed based on the evidence and also using a standardized process, so-called GRADE process for guidelines development. The knowledge and the new developments in this field have led to new approaches, new medicines, actually, like bedaquiline, delamanid, have been developed, and we in WHO had to, the Global TB department developed the new guidelines and tried to keep the pace with all these new developments. Obviously, they became many documents, and at some point WHO took a decision to try and consolidate everything into one document, which was done towards end of 2018, but in March 2019 this document came out. So this is the document that currently sits on WHO website and can be downloaded, the WHO consolidated guidelines on drug-resistant TB treatment that includes all the recommendations that are valid and replaces all previous guidelines. So it tries to encompass all available knowledge on treatment of drug-resistant TB. Just a few quickly to go through what were the main changes, because obviously there were some things that remained the same, and there were some changes, minor or fairly significant, that have been included in these consolidated guidelines, mainly stemming from the guideline development and the guideline development group meeting that happened in summer of 2018. So probably all of you being involved in TB control and in the management of drug-resistant TB know about these major changes that were the new longer regimens with no injectables have been introduced basically with after that meeting in 2017 and the WHO guidelines that came up at the end of 2018. So there were obviously the related changes in the grouping of the second-line medicines and composition of the longer regimens. Something that remained almost the same were, of course, the start of antiretroviral therapy for patients with MDR-TB, the use of surgery or models of TB care. That part of the guidelines didn't change. There were minor changes, the kind of a tighter recommendations before starting the shorter injectable-based regimen have been introduced, but the injectable shorter regimen remain in these guidelines. So, I mean, that obviously the classification of the second-line medicines was one of the major changes. There were some medicines that were simply taken out from the table and from the list of the second-line medicines, that some injectables like kanamycin and capreomycin, and there were some new medicines like bedaquiline or repurposed medicines like linezolid were really brought up in terms of priority to the group A, that are while designing the regimens, these are the first drugs to include, as well as there was some serious reshuffle of the medicines based on the evidence on their efficacy and also the safety in this table. To summarize, since I don't have much time, the consolidated guidelines introduced the fully oral longer regimens for MDR and rifampicin-resistant TB with the significant changes in the regimen components, and also increasing at the same time and emphasizing the new requirements because of that for the drug susceptibility testing and pharmacovigilance, and a little bit more tighter criteria before putting patients on the shorter regimen with injectables. And something also, last but not the least, that I would like to mention, the guidelines have started to introduce a new and expanded scope for the operational research in drug-resistant TB treatment, and I'm glad to hear that many countries are already adopting this in the practice and in the management of the TB national TB programs. Having said that, and while the guidelines, they were already launched in March 2019, there was new evidence that was promised to be available to WHO in the same year. And while we had to balance the decision whether to start already change the guidelines that have been released just recently, and I know that many national TB programs and countries really sometimes are not happy with WHO changing, updating guidelines very frequently. But the decision was to go for that and try to do another guideline development group meeting and look at the data on the three pieces of the new data and update the guidelines. So we had the data on the programmatic implementation of the shorter regimen with bedaquiline, so without injectables, the big programmatic implementation in South Africa, the results of the so-called NICS TB study on the regimen of 6 months provided by TB Alliance for patients with XDR TB. Also, we have been promised and provided with the data from the NTB project, NTB study, observational part of that project, mostly focusing on the use of bedaquiline for longer than 6 months and use of bedaquiline and delamanid concurrently. So two gaps that we really had no evidence for in the previous guidelines. So there were 4 main PICO questions that guided that review, and they are mapped here on this slide against the data that we have received. I will not go through all this in detail. You will have the presentation. But the process have the guideline development group finished, and unfortunately we don't have the guidelines. They are being developed right now as we speak. By the end of April, WHO is planning to release the updated, consolidated guidelines, but since there were some significant changes, we thought that it would be good to give the heads up to everyone and release the rapid communication in December. So basically, what will happen, all basically regimens for both MDR, rifampicin-resistant TB with the release of these guidelines can be without any injectables, so they can be all oral. There will be, of course, the patients with severe extrapulmonary, with serious TB disease will have to be going through individualized approach and regimen to be designed. But for certain patients without those conditions and no previous exposure to the second-line drugs, they can be treated with a shorter all-oral regimen. Of course, I mean, many countries, especially in this region, may think that what will be proposed may need some further modifications. Again, there is a place and space for the operational research in that area. The BPAL regimen was also reviewed and showing an efficacy against XDR TB, but most probably the recommendation around this regimen will be for operational research for many reasons that we can discuss when we have if you will have a question on that. But there were factors that were precluding from programmatic recommendation for programmatic implementation of that regimen. Just quickly, because my time is up, on a few next steps. Again, as I said, the consolidated guidelines, we are planning to release them in April already. What we are trying to do, we're trying to accompany the guideline document with implementation documents, so-called companion handbook, the treatment chapter. There will be actually, there is already the kind of help to assist those that are deciding to go for operational research. There is a protocol and the package that have been developed together with the Special Program for Research and Training, the TDR. It's on their website, the so-called short package, and it also contains the data collection tools, etc. We are planning to convene the global consultation right after or soon after the guidelines are released, probably in May, but that will depend now on some other things happening in the world. So thank you very much.
Thank you, Fuat Mirziayev from WHO. We'll have a coffee break now. Hot drinks will be served in the lobby area. Please be back and seated by 11 a.m. Thank you. We are returning back. Shall we start? We are returning to the theme of putting policy into practice. I would like to welcome back our chairs, Dmitro Danchuk and Yana Tirleeva. Following the next presentations, we'll have our first panel discussion of the day. This will be a chance to really delve into the topics brought up so far. Please make sure to use the hashtag TB Symposium and tweet during this whole event and engage into the discussion over the Twitter too.
Я надеюсь, что все вернулись с кофе-паузы, и мы хотим пригласить следующего.
I hope everyone is back from the coffee break. I would like to welcome the next speaker, Asmir Ismailov from Stop TB Partnership, to report on the country's commitments based on the high-level UN meeting on TB and about the financial requirements to Eastern Europe and Central Asia countries. Thank you very much. It's always hard to start after the coffee break. When I was preparing my presentation, first, I would like to thank the previous speakers. They've covered half of my presentation already, but that's good. I will have more time for other subjects. Before we start, I would like to remind you and to update you on what TB Partnership is. And like Sebastian said in the beginning, partnership is the key to success. Stop TB Partnership is the key, and more than 2,000 organizations are part of Stop TB Partnership, and I'm proud to say that MSF is one of them. The mission is synergetic with all other organizations, and we're all trying to ensure for each TB patient access to TB diagnostics, treatment, to reduce transmission, social burden, and develop new strategies to counter TB. The goal is clear. I'd like to remind that the major mechanisms and initiatives of the partnership that you know is the global drug facility. Besides, many of you know that there is such an initiative as TB Reach, and the technical assistance provided by our organization for targeted global funding worldwide, and preparation for proposals for the windows declared by the Global Fund. Stop TB Partnership has been developing for several years the global TB control plan, and recently the latest version was published. Actually, the goals and the principles did not really change. They're the same. They are focused on people and those famous 90-90-90, to detect 90% of TB infected people, provide them with treatment, with drugs, with diagnostics. RIF TB, MDR TB are also included, as well as prevention. Within first 90 goal, we target also key populations, and the third 90 actually tells us about the success of this process. Yulia Chorna has already provided you with information on what happened in September 2018. I have brought you several copies of the declaration, the first TB declaration, which was signed by the member states. It is in Russian. And I hope in the afternoon, together with the main goals and responsibilities, this declaration will be circulated to the delegations of today's symposium. Stop TB partnership went beyond, and based on the goals and objectives adopted as the country's commitments, for each country, the goals were distributed on the yearly basis. This is very good information for us to be able to model our work in the countries. In order not to repeat myself, I would say that these goals for countries between 2018 to 2020 and for the remaining 3 years, 2021-2022, they are there's a breakdown covering TB in general, childhood TB, prevention, need in resources, and treatment. We didn't do this before, and if somebody is interested in this information with regard to resources required to eliminate TB in the country, we're always ready to help you and to explain how to do that. Besides, I'm urging you to visit our website with this information. And now a few words and numbers with regard to the 8 countries present here. I also can see members of the delegation from India and Afghanistan. If you are interested to speaking about your goals in your countries, I would be happy to do it during the breaks. I'd like to draw attention to the fact that on the charts, the numbers over the 3 years basically do not change. And they are related to the numbers of TB treatment in children. It is also clear that the numbers vary a lot because of the number of population in each country. And of course, Russian Federation and Uzbekistan will be leading here due to the population and the if we know the goals for each country, it would be also good to know how much money would be needed for that, what funding is required, and do we have gaps in funding. If we look at the last numbers, we calculated that for the remaining 3 years until 2022, the countries globally have a gap, which is about 49% of what a country has. This is the global number. And I took courage to calculate the costs for our region. And as you see, about 5.4% of all the needs to combat TB this is the amount of funds we would receive from the Global Fund. And we should not rely on this funding. We should look for our own resources for this purpose. If we look at the breakdown of this amount by 3 years, we can see that the numbers are different and reducing every year. In this case, if we look at the last chart and the last graph, you can see the difference between difference in the amount of funds between 2016 and 2022. Now, the next slide is very interesting. It shows how close we are in reaching the goals we set in terms of global TB control plan. And you can see that actually by the end of 2022, there are still a lot of activities to be accomplished. For example, in MDR TB control, we have reached only 52%. I have some more handouts with me. They will be looking like this, and I hope the organizers of the symposium will distribute them tomorrow together with the certificates. Here there is the information on every country in terms of goals and in terms of how we approached the goals. There will be 3 copies per each delegation. So in the end, we know that we have still a lot of work to be done in terms of strengthening the advocacy. We all hope that the national programs will be developed and planned with regard to the goals developed and signed by the countries as the part of this declaration. And the most important thing is that we all should build our strategic plans on these goals to make them more realistic. In conclusion, I would say that, you know, this slogan, and in our case, that per each dollar of investment invested in TB control, dozen will return. And this is what we should tell our financial guys in our countries. Thank you very much. I'm ready to answer the questions. Thank you, Asker. We will have time for discussions, and I would like you to join us here on the stage. And I'm happy to invite the next speaker, Dr. Alena Skrabina from Belarus. We have a long-term experience of cooperation and collaboration and partnership in many projects related to MDR-TB. Dr. Skrabina has years of experience as a clinician, as the health manager. She is also a member of numerous international committees that develop guidelines and help national programs in countering TB. Today she will be speaking about shorter treatment regimens and BPAL regimen. Good morning, dear colleagues. First of all, I would like to thank the organizers for the opportunity to be present here and to share our Belarus experience in terms of operational research of shorter treatment regimens, all oral regimens. I'm not going to speak much about this slide, but I'd like to say that Belarus never used Bangladesh shorter regimen, injectable regimen, for various reasons, because we have quite high level of resistance to second-line drugs. And besides, we have high level of resistance to pyrazinamide in Belarus, around 75% in people with the resistance to rifampicin. They also have resistance to pyrazinamide. Some technical problems. And besides, we didn't really like that in this Bangladesh regimen there are injectable drugs. And we had a dream to get the WHO recommendations or guidelines in terms of transferring to all oral treatment regimens. When the guidelines were published, our country had already new drugs. In 2015, we started using new drugs, and we didn't even try this Bangladesh regimen, which many countries did. Regarding modified shorter regimens, I'd like to point out that you can see that the urgent notification that happened before consolidating guidelines of the WHO was published in August 2018. And according to these guidelines, the World Health Organization encouraged the member states to start all oral regimens as a part of operational research. And we were encouraged, we had been encouraged before WHO's encouragement. That is why in the end of September, we already enrolled the first patient in this shorter regimen. A huge intensive work had been predecessing this. We took the generic protocol as the basis, developed the criteria. This protocol had to be approved with the National Ethics Committee, and we got the approval in the WHO Office for Europe. This took certain time, but still I think this is great that the first patient on all oral regimen in Belarus started treatment in the end of September 2018. And now, as you can see, there is a new communication which was mentioned by Faid. In the bottom of the slide, you can see in the bottom the guidelines published in December, where the WHO encourages the countries to use shorter regimen called BIPAL, and to use it as a part of the operational research, not programmatically, but in the operational research. Regarding preparation to the operational research, it is clear that the protocol we used, it was a Belarus protocol, and it had certain goals and objectives. First of all, to define treatment outcomes for patients on new modified shorter all-oral regimens. And as a secondary objective, to assess its safety and relapses, level of relapses after the operational research. There are certain criteria for patients enrolled for this regimen, and you probably know, you surely know, that the WHO Office for Europe in December initiated the new initiative, implementation of new shorter regimens, and actually three new shorter regimens, all oral regimens for patients who have rifampicin-resistant mycobacteria, but no resistance to fluoroquinolones and injectable drugs. When we followed the same principle, but we excluded patients on injectable TB drugs because we thought that was important at that moment. Here's our protocol. The treatment lasts for 39 weeks. It will be introduced in all countries in our region. You can see the list of the drugs from groups A and B, on condition that the patients are not resistant to these drugs with laboratory confirmation. You can see that in our protocol we use the dosages recommended by the WHO in the consolidated guidelines. It's very important to pay attention to this because in the previous guidelines, 2 drugs were in lower doses. The price of our short course is approximately $1,500. This is the monitoring protocol. I'm not going to speak much about it, but you can see that first before you can see the indicators before the launch of the study, then 2 weeks later, since it is related to linezolid administration, and then every month during 24 months. And by the way, after treatment completion. This will be the difference from the shorter regimens we are starting together and which are initiated by European WHO office. And our operational research will also last for 24 months. As of today, these data are a bit outdated because when I submitted this report, when I sent it a few months ago to the committee, now we have 303 cured patients, enrolled patients, but of them 46 were excluded because they were resistant to fluoroquinolones or injectable drugs. Of those who completed treatments, well, we have 4 cases, 4 deaths, not related to TB, to ontological disease, and 1 suicide. The rest of the patients are still on treatment. Regarding TB REACH grant, Oskar has mentioned that already. The countries had an opportunity to submit the application for TB REACH grant, and Belarus did that. And thank God we got the positive decision on that. And we are starting the operational research as a part of TB REACH grant. This is BPAL regimen. I will elaborate on which regimen is that. It includes not only the study of efficacy and safety, but also the patient's quality of life on shorter regimens. Patients with rifampicin-resistant TB compared to standard regimen.
This is the design of the study. We started with the standard cohort, and as soon as predominant will come, we'll start the next cohort, and for them, they will have the predominant treatment. Also, the inclusion and exclusion criteria. Well, first of all, it's the patient willing to sign informed consent and bacteriological or molecular genetic confirmation of resistance to at least rifampicin. And the exclusion, well, the exclusion criteria is if the patient cannot take, for example, the oral forms. This might happen. And some other exclusion criteria, for example, a known allergy or a QT interval corrected for adjusted for over 500 milliseconds. And if it's a woman, if she refuses effective contraceptive, or a pregnant woman, or a child under 18. These are 2 main regimens that we will use. The bedaquiline predominant linezolid with moxifloxacin or clofazimine. If the patient has resistance, and they all have bacteriological confirmation, so if we establish resistance to any of the fluoroquinolones, this will be clofazimine. If there's no resistance, then they will get moxifloxacin. Also, I want to draw your attention that in Belarus we are not using, and we will not use, linezolid 1200 because we think it is dangerous. We have a big experience of application of linezolid. We have been using it for 10 years already. That is why we are entitled to say that yes, we have a lot of experience, and we know that even 600 linezolid for many patients is a high dose in terms of adverse effects, and that is why a quarter of the patients in this or that way are switched to a smaller, a lower dose, 300 milligrams. This is the investigational schedule. You will get all the slides, so I won't dive into it. It is more or less the same as the schedule for shorter regimens. And in the conclusion, I would like to say that we have started 2 new short regimens, 2 new short courses, one in 2018, and now we start the other one with predominant. I think it is really, it's like a space journey if we compare it to what we had before. And I always put my granddaughter on the final slide, because She is the symbol of development for me, and our program in Belarus also is developing. Because, well, I understand that we might have flaws. I hope you are you will be a bit taken into the consideration our conditions. But I would nevertheless I would like to say that now I think is the best time ever in this program, because now it's finally the time when we can give good oral forms to our patients, and this is the future coming to reality. Thank you. Thank you, Alena, for the presentation. Belarus, as always, demonstrates the breakthrough new experience in introducing new approaches. Now, I would like to invite Naira Kachetran, who has tremendous experience with TB programs. Today, she represents the Armenia NTP, and also she is an expert of the WHO, and she will present a report on the analysis and gaps in implementing policy and practice. Hello, dear colleagues. So it happened that for 10 years I have been working with MSF. So then, as our mission was over in Armenia, I started working with the national TB program. So it seemed like a very good handover from MSF to this different life. But anyway, best practices flow either way. I'm also learning how to work now in the state-run system, in the program. I would like to present a small achievements and gaps analysis, which we did, looking at our policies and looking at which of them were implemented. The main policy on TB, on TB control in Armenia, is the current strategic plan for tuberculosis. It is in effect until 2020. I would like to say that now the country is developing a new strategic plan. So all these analyses, they should and they are considered in the preparation of this new document. Of course, in the current plan, one of the goals is to strengthen the tuberculosis control system. We want to improve the EPI situation, and we want to promote civil society engagement. There are some general framework goals that are set usually, but what do we mean by this? What do we how are we planning to implement them? If we look at the legal framework, what do we have in terms of that? Oh, the Russian slide is too far from me. I'm sorry. So, we have some achievements. One of those is that the Ministry of Health of Armenia has adopted some strategic steps. TB elimination is, let's say, the main goal for these years. Yeah, the healthcare reform was already mentioned, and of course the matter of inpatient facilities is quite crucial. We do have the shortening of inpatient period, even though we haven't switched everything to outpatient provision. And of course, in terms of drug procurement, we already have some good experience. We use the TB drugs are now procured with state budget money through international procurement platforms. But of course, we still have challenges. We have things to improve. We have the limited role and mandate of the Office of National TB Program. This has been noted by the WHO expert, which assessed our program recently. We have some technical flaws. We have issues with staff resource, with human resource. Of course, we have weaker interagency cooperation. For example, the Ministry of Health and the Ministry of Finance, the Ministry of Health and the Ministry of Social Services. There are a lot of things to be improved here. And of course, the role of primary level physicians in finding and countering TB. If we look at the newest methods of case finding, our latest clinical document, which was developed to implement the latest WHO guidelines and adopted in 2019. And in terms of diagnostics, I would like to say that GeneXpert now is the primary diagnostic method. But of course, I can't say that we have switched to it completely. We have only started this method this year. Yes, we have a developed network. We have the GeneXpert equipped labs even in the regions, but still we are on the path of implementing this methodology. We have the DST obligatory and of course LPA and GeneXpert. So the programs related to NRL, well, as discussed, these are the matters of coordination. And this is the adoption and implementation of the NRL strategic plan. We have to develop the guiding principles for this and improve the infrastructure. And in terms of the periphery, we have improvements of sputum collection and sample transportation that really needs improvement. We have the system, but it is under efficient and there are issues with this. As for active case finding, in the new guidelines, for family contacts, children and adults, also we have active case finding among people who live with HIV, and in the new guideline there is also the interferon test, and also there's obligatory testing of contact children under 6 months if they have a positive response for tuberculin tests, and also X-ray or digital fluorography are used for contacts among adults. Also, we have the 6-month daily isoniazid as a preventive therapy. We also have the updated rifampicin plus isoniazid course and rifampicin course. But this year we use only the first option out of the 3. In the next years, we will most probably switch to the rifampicin. Well, if you look at this, of course we still have issues where we need to improve. We need to expand active contact tracing. We have some low figures. We are still analyzing this, and we will develop specific actions to improve the coverage. Of course, we develop and implement mechanisms with clear definition of roles and responsibilities regarding TB at primary care level. In TB treatment, all the WHO recommendations in our new guidelines are there. We don't have these the category 2 regimens, which have been used for quite some time in our program, and also for the treatment of TB HIV co-infection. We have revised the guidelines from September 2019. We have the new way to do it, and for MDR TB also we have updated everything in line with WHO guidelines. Even shorter regimens of MDR TB, they are in our protocols. but we will start using them as part of the operational study with WHO. Now we are developing these protocols, so hopefully from May we will be able to recruit patients to this new program. As for pharmacovigilance, we do apply it in the country, but we still have issues in the regions. There are also issues with coordination. We will consider this, and we develop a set of measures to improve this sphere as well. The patient-centered care. I can only briefly mention that we use 3 models. Mostly this is home-based treatment. About 30-70 patients receive it every month, and it is regardless of the patient type or process localization. We have also DOT, the VDOT, and the MSF helped the program with this. We still have some technical issues, but we are trying to expand this program. And of course, the innovation is family-based DOT, where patients receive treatment observed by a family member. We are now transitioning from a pilot, which we did with an American institute in Armenia, and we are now implementing software for this. In terms of drug management, I would like to say that almost all the drugs are registered in the country except bedaquiline. Except dilamanid, it's not registered, and bedaquiline is registered but is not included in the essential list. So the first line is procured with the state budget money, and as for the second line, like 70% are covered by the Global Fund and 30% are covered by the state. I'm sorry for overstaying my time here, but I'm almost done. Of course, we have issues, but we try to move ahead. Like in these children's games, we jump over the obstacles. Thank you. Thank you, Naila. Please join us here. I'm happy to present Dr. Nana Kiria from Georgia. Dr. Kiria has been working in the National TB and Pulmonology Institute, and she has big experience working with MDR-TB in particular. Dear chairs, dear colleagues, I would like to briefly explain the factors that helped the process of smooth transitioning to modified oral short regimens for TB, for MDR-TB in Georgia. Up until 2016, Georgia was a country with high burden of MDR and XDR-TB. Among the new cases, MDR-TB made 10.3%. Among previously treated patients, it was 38.4%. So 17% of patients with MDR-TB had XDR-TB. The resistance to fluoroquinolones was noted in 33% of cases, and 41% had resistance to injection drugs. The treatment success result was also quite low. In the 2014 cohort, it was 49%, and for rifampicin-resistant TB, for RR-TB, and 30% for XDR-TB. The chronology of access to new TB drugs was the following. From 2011, we had only sporadic cases of application of bedaquiline as part of compassionate treatment. From 2013, the number of patients who were included in this program went up significantly. In 2014, the MSF supported the scale up of CU program, of compassionate use program, and we started the application of bedaquiline and delamanid as part of the chemotherapy regimens for all the patients with XDR-TB, with resistance to fluoroquinolones or injections drugs, and for patients with MDR-TB with failures of treatment. And from 2015, Georgia has universal availability of these drugs, and we have updated the guideline and created the system of pharmacovigilance. On February the 1st, there's a typo there. On February 1st, 2020, in Georgia, we have used bedaquiline to treat 677 patients. We have 11 children among them. Delamanid for 283 cases, and that includes 23 children. So simultaneous or consecutive application of these drugs were noted in 93 patients, including 8 under 18.
Application of these treatment regimens based on bedaquiline and delamanid improved significantly treatment outcomes. The 2016 cohort, in this cohort, the success rate compared to 2014 increased by 18% among patients with rifampicin-resistant TB and by 25% in patients with MDR-TB. After the first in the history, the top-level meeting of the General Assembly of the United Nations on TB, revolutionary changes were introduced in management of rifampicin-resistant TB. After publication of the new WHO guidelines for MDR-TB, Georgia immediately started implementing them. The process of transition to all-oral regimens to treat rifampicin-resistant TB and MDR-TB, especially for modified, shorter treatment regimens, we had the following plans. The predictors, the 4 clinical trials were the predecessors for this transition. These studies were called NTB, Stream Stage 2, Xenix, and Simplicity. These clinical trials included 131 patients. Of them, 88 patients were diagnosed with MDR-TB, and of them, 66 patients were on all-oral shorter treatment regimens. To implement the new WHO guidelines, we updated our clinical guidelines and trained the staff. The update was related to modified all-oral shorter regimens. We use 2 regimens, all-oral regimens. One is longer for 18-20 months, and we use a programmatic shorter modified treatment regimen, all-oral treatment regimen. Besides, in shorter regimens, we use the following: bedaquiline, linezolid, levofloxacin, clofazimine, cycloserine with delamanid, the first drug, the drug of the choice, which will change one of the backbone drugs in case of toxicity. In longer regimens, the backbone is bedaquiline, linezolid, levofloxacin, clofazimine, complemented with the drugs which a patient is susceptible, the mycobacteria is susceptible to. The updated guidelines also include pulmonary respiratory rehabilitation after treatment. We have a new rehabilitation center for pulmonary patients, which started operating. This also involves expansion of active screening for TB, scaling up strategy and treatment of LTBI. Previously, we used only isoniazid preventive treatment. Now we are using isoniazid for 6 months only for children under 2 years of age, and to treat patients with HIV TB co-infection on ART based on dolutegravir. In other cases, we use isoniazid with rifampicin during 3 months, 12 doses, 1 dose per week. Also, there are some updates related to surgical treatment, TB meningitis, laboratory monitoring. These are the outcomes of the new guidelines. We have updated our guidelines in 2019 in January. Despite the fact the ministry approved the new guidelines only in June, starting March last year, we had started using new all-oral regimens. And in 2019, until 1st of February 2020, 281 patients started treatment. Of them, 209, which is 74.4%, were prescribed with all-oral regimens. Of those 209 patients, 149 patients had longer all-oral regimens, and 69 patients all-oral modified shorter regimen. 10 patients have completed treatment, a shorter treatment regimen, and with a successful outcome. So, which means the shorter treatment regimens are the best way to treat patients, because patients' adherence is at a very good level. Patients have motivation, and this is the future of our TB control. Thank you for your attention. We would like to invite the next speaker, my colleague Olga Semak, who represents one of the leading regions in Ukraine, Zhytomyr, to share the experience of Zhytomyr Oblast in terms of transition to all-oral treatment regimens as the future of MDR-TB treatment.
Маю велику честь виступити на такому важливому зібранні і хочу подякувати організаторам за таку можливість та партнерам нашим за довіру озвучити попередні результати нашого спільного з МСФ проекту.
Dear colleagues, thank you very much for the provided word. And my name is Olga Semak. I work for the Zhytomyr TB dispensary, and we are now conducting the short all-oral treatment regimen without the use of injectables, and we consider that to be the good option for the future treatment of drug-resistant TB. So let me share a bit of our Zhytomyr experience with you. This is a map of Ukraine, and we can see the TB incidents here all around the country, including new cases and relapses for the year 2018. You can see Zhytomyr Oblast here, indicated with an arrow. And as you can see, we are the MDR TB high burden oblast. Zhytomyr Oblast is a region situated in the north of Ukraine, with a total area of around 30,000 square kilometers. The population is about 1.2 million population. 42% of those is the rural area population. The administrative center of the city is the city of Zhytomyr, which is about 140 kilometers away from Kiev city. The population of Zhytomyr city is almost 264,000 population. The Zhytomyr Oblast is subdivided into 23 districts. You can see the list of the big cities in the oblast, and the northern part of the oblast significantly suffered as a result of Chernobyl catastrophe and has been included into the Chernobyl exclusion area. Part of it was included. We have 300 beds in the TB dispensary in Zhytomyr city. We have 2 spa centers, one pediatric, 140, and one for adults, 100 beds. TB care in the region is provided by 27 TB clinics, TB cabinets, basically, this is what we call them. We usually have one TB nurse and one TB physiatrician there. We have 30 laboratories, level 1, and one laboratory level 3 at the oblast level. And we also have 72 TB MDs in the TB dispensary and all around the districts. Let me briefly update you on the epidemiological profile of Zhytomyr region. So the incidence of all forms of TB for 100,000 population in 2018 was 60.3. In 2019 it was 57.9. Co-infection of HIV and TB, it was 9.7 compared to 8.6 in 2019. Incidence for DRTB, it was 17.9 in 2018 and 12.9 in 2019. Incidence of relapses, it was 16.2 and 10.6 respectively. Incidence for new cases and relapses of TB, 76.5 in 2018 and 68.6 in 2019. And mortality rate from TB was 10.8 and 8.7 respectively for 2018 and 2019. So we basically see insignificant trend towards reduction in that figure. So let me show this. Let me also show you the cohorts of 2018 and 2019 for drug-resistant cases. 47.5 have been treated and 48.6 have been treated in 2019. The number of those who died, 15.9 in 2017 and 13.5 in 2018. Lost to follow-up 13.6 in 2016. In 2017 it was 12.3, and failure was observed in 18.6% of patients in 2016, and in 2017 that figure was 22.8. Speaking about failure. And we see that the problem of drug-resistant TB is still there, and it is really a top problem. So, we initiated the project jointly with the MSF colleagues. Sorry, I'm a bit nervous. So we initiated the project jointly with the MSF colleagues in March 2019, after we signed the memorandum. So we used the short duration treatment regimens as well as individualized treatment regimens with the use of 2 new drugs, delamanid and bedaquiline. But the priority for us was actually to have that was actually initiated back in 2018, but the priority for us was the project of March 2019, when we started the implementation of the operational study that included only the use of all oral short regimens with the use of new drugs and repurposed drugs. And the cornerstones of those were as follows: the regimen with new and repurposed drugs for 9 to 12 months, depending if there was any resistance to fluoroquinolones. The first was levofloxacin, bedaquiline, linezolide, ciprofloxacin, cycloserine. And if it was resistant, the patient was resistant, it would be bedaquiline, linezolide, ciprofloxacin, delamanid, cycloserine. We also had the possibility of early discharge to ambulatory care, to outpatient care, basically. We focused very much on the early side effects and management. That was a very good prevention of the potential failures of treatment. We also focused very much on comorbidities management, as well as provided psychosocial support and care to patients, which is very important for TB patients. For the period from March 2019, we included more than 150 patients into the operational study. Preliminary analysis took place from March through July 2019. The 83 patients were proposed with enrollment. 7 patients, which is 8% of total, refused from this participation. 76 of them agreed. They started with levofloxacin, 54 patients, which is 71 number, and those with delamanide treatment regimen were 22 patients. And 74 patients have been included into analysis, 53 on levofloxacin and 21 on delamanide. 2 patients have been excluded because they were switched to susceptible TB treatment regimen, and we got the data which did not confirm the MDR TB, drug-resistant TB in them. 11% of patients, which is 8 patients, died within 6 months. 1 person was switched to ITR. 1 person on an individualized treatment regimen continues his chemotherapy, and he achieved sustainable sputum conversion. 65% have remained, 65 patients have remained on the OR treatment regimen. 14 have been switched to from levofloxacin to DLM treatment regimens after DST test results, which confirmed the resistance to levofloxacin. 2% switched from linezolid to delamanide because these patients had some severe adverse effects, side effects. These were neuritis cases. 18 patients still remain on delamanide treatment regimen, and 31 of them remain on levoflox. During 6 months, 65 patients had conversion. During that period, 54 of them converted, then renamed negative still at the period of 6 months. They basically didn't have any positive result. 1 had no baseline culture test results. Speaking of results of the study, so there are some basic characteristics. Demographic features are as follows. 20 women have been included, which is 27% of total. The average, the median age of initiation was 41 years. Those under 18, only 2 patients. Those under 25, we had only 6 patients, which is 8 patients of the total. The BMI index less than 18.5 was observed in 24 patients, which is 32% of the total, which is quite a significant number. Speaking of diabetes mellitus, it was observed in 5 patients. HIV was diagnosed in 14 patients. So basically you have all this data on the slide. I think you can see it very easily and clearly, I hope. Pay attention that 39 patients had problems with addictions. They were dependent and addicted to alcohol, some of them. Some of them were addicted to substance abuse. And the total number was more than 53% of the total number of patients analyzed. Seems like I'm pressed for time. That's it? Somebody says, I just like that previous slide which you showed to me. It seems like our medical coordinator focused his attention on this slide. So let me focus on that as well. I wanted to speak about the side effects rate, occurrence rate. At least one of side effect was observed, like anemia, for example, polyneuropathy. We had 26 patients like that, which is 35%. 38 cases have been registered. 3.8 months would take to develop that. 14 patients had at least one side effect, one unwanted effect. QT interval was increased in 10 patients. Liver problems were not observed when analyzing the results of 74 patients. Optical neuritis was found in one patient, and situations that would bring to irreversible switch was only in one patient. Treatment was going on for 7 months, and the decision was made really to change the treatment regimen. We didn't have any single case of pregnancy, and 8 patients, which is 11%, had lethal result, but there was no any causal relationship found with the intake of drugs. We have still to go deeper into investigation of these results, but we do not see any direct causal relationships.
Строчку предыдущего слайда, то, что медицинский координатор имел в виду. Вот если вы предыдущий слайд нам дадите.
On the conversion, yes, that would be slide number 3. We had it before. Yeah. So the results of treatment on
these are the patients that have been included, 74 total, 8 died. We didn't have a loss to follow-up, didn't have failures, 65%, which is 88% of the total, still alive and continue their treatment. And during 6 months, 54 patients converted, which is 100% basically. And the period of time that it took was only 2 months. Any other slides you would like to look at? Okay, it seems like this is it.
Thank you, Olga. You shouldn't be worried, you should be proud. You should be proud of your results. Please, take a seat here. Now, I have the honor to present the next presenter, Natalia Campos Rodriguez from Public Health Center. Natalia is a lab specialist. And today she will present on access to the methods of TB fast diagnosis. Hello, dear colleagues. The use of fast molecular tests of the rapid TB diagnostic methods, I'm sure you know that this is the main requirement to TB treatment and prevention. We all know that late increases the mortality and the transmission. So scaling up the rapid diagnostic methods, including the methods for primary detection, was the main condition to decide on the model for the GeneXperts systems in our country. Oh, sorry, I forgot to switch the slides. We have started using GeneXpert systems from 2012. Initially, they were installed in the regional TB dispensary clinics, also in the penitentiary system and in the 8 centers. Later, as part of the Global Fund aid, we have procured more gene experts and had installed them at primary care level to be used as primary tests. So, regardless of the fact that we have rapid molecular methods, we still are using sputum microscopy to find TB. The full transitioning to rapid methods is a complicated, long, and a step-by-step process. As of today, in Ukraine, we have 690 laboratories, the first level, which do microscopy to detect TB. And in order to replace microscopy at all, we need some huge financial resource. In order to fully switch to rapid tests, we need to ensure high-quality logistics system to make sure that different biosamples are transported accordingly. Because from 2019 we started using the gene expert systems to detect not only TB but also HIV and hepatitis. And in order to switch to rapid diagnostic methods, we need to build up the system in such a way, to install gene experts in such a way so that they would be installed following patient pathways, so that the system would be flexible. Because if in case of something we understand that that particular gene expert is ineffective, is not working for rapid diagnostics, so that we could redirect the sample or the patient to another facility to ensure that things are rapid. So, if we want to stop all microscopy and get to only rapid methods, we need strong advocacy and we need access to solid financial resource. From 2019, Ukraine has fully switched to the use of ultra cartridges. The procurement of the cartridges comes from two funding sources. With the Global Fund money, we cover the needs of systems installed at primary level. And in 2019, we have spent about $65,000 or $50,000 from Global Fund money. And 100% coverage of the systems that are installed in regional labs, well, that included about $750,000 from state money. When we started implementing the ultra cartridges, we understood that their use will not ensure rapid gains in TB cases, but for certain categories like children, HIV-infected patients, and patients with negative microscopy, for them ultra cartridges are more effective than classical cartridges. Also, our country is ready, we are getting ready to the use of XDR cartridges. We have developed a project, an algorithm, which includes XDR cartridges. We have calculated the needs for new models and the needs for the XDR cartridges. The infrastructure as such, the equipment, without the staff, without the ongoing funding for the logistics, without a proper patient selection and proper taking the samples, we will not have the effective TB detection system. So in order to scale up the potential, the capacity of molecular genetic methods, well, we need to understand, as we are undergoing the healthcare reform now, we need to see how patient pathways will go and how biosamples from other nosologies will flow, so that we could complement our plans to introduce molecular methods, so that we could also ensure that resources are spent efficiently and effectively. Thank you. Thank you, Natalia. Please take a seat, join us here. We are done with the plenary section here. And we would like to say thanks to all the speakers. It was very, very interesting. And it was really on the point. We see that in many countries there is a great deal of progress with piloting. And the topic of our session here is switching from piloting, from sporadic projects, to scaling up all over programs. So the diagnostics and treatment will be provided for all the patients, for all the people who need that. Now, I encourage everyone to join this discussion. We have time to ask questions to all the participants here in the panel. Please.
Профессор Василий Петренко, Медуниверситет, город Киев.
Professor Vasily Petrenko, Medical University of Kiev. First of all, I would like to say thanks to the organizers of this regional symposium for having this significant event in Ukraine, the city of Kiev. And I welcome all the participants who, in this quite epidemiologically complicated period, were not scared and came here, and we all take part in this symposium. So, with great attention, I have heard all the presentations. Yulia Chorna, Yana Tirleva, Mirzoy, Ismailov, Skrabina, Khachturan, Kyrios, Mark Rodriguez. They all gave fantastic speeches, but one thing I noted in particular by Ms. Nano Kyria. You briefly mentioned that you created a new rehabilitation center for patients with pulmonary. What was the facility? What were the improvements? Because in Ukraine right now we have some complicated issues regarding the so-called sanatorium. What we can learn. Thank you. This is a very interesting question. In Georgia, we have built a brand new rehab center in Abastumani, which is a high altitude resort. Old TB specialists probably know that in Abastumani we have had a few of these so-called sanatoriums for TB patients treatment. At the moment we do not have the sanatorium treatment as such. We don't have these sanatoriums. This is a rehab center for patients who are cured already, who have the outcome of TB cured. They still have some residual pulmonary issues, obstructive pulmonary disease, but the pulmonary inefficiency should not exceed category 1 or 2, because in high altitude, if they have some severe pulmonary insufficiency, then it could get complicated. So these are for patients after pneumonia, patients with chronic bronchitis, relapsing bronchitis. This is a purely rehab facility where they use physiotherapy and corresponding methods, massages, breathing exercises, and then we evaluate also. Also we did it in the following way. This is a rehab facility where the course lasts, depending on the diagnosis, for 6 to 12 weeks. And there is a 20-day inpatient course, which is one of the components of the general rehab course. So before we send the patients there, we look at the charts. We have a consilium that looks at the patient charts, and then we assess the baseline data, the body plethysmography data, or computer spirography data. We look at counterindications, indications for the rehab measures. Then, after the patients undergo the inpatient course, the inpatient rehab, then we compare all the indicators for external breathing with the baseline. If we see no improvement or we see worsening, we will not recommend the continuation of the course. Also, in inpatient conditions, the patients are learning the skills for continuing rehabilitation as outpatients. Next, we want, on the basis of this center, we want to create the so-called School of Pulmonology, where they will have the information for all the patients with chronic obstructive pulmonary diseases, and then from time to time we will provide follow-up for these patients. We will provide this follow-up, and this is very interesting. I think it's the first precedent where we have created a guideline, and it was recently reviewed by the Ministry of Health of Georgia. It has been approved, and we have had a few experts taking part in the development of these guidelines. The guideline was created by not only the Association of TB doctors and pulmonologists, but also we had rehabilitologists. They also joined the working group extensively. And we had experts from the UK and the United States who were very, very helpful. This year, we want to have a small conference there, let's say an expert meeting, so that they could look at our rehab center and so that they would provide further recommendations on how we can continue improving. Because it turns out there are a lot of examples of switching former TB sanatoriums into rehab centers, but it turns out there never has been a case of such a narrowly specialized pulmonology rehab center. Thank you. Irina, please. Thank you so much for this detailed explanation. I also had a question, actually. That is why I just want to clarify. You mean that this is a rehab not for patients with TB, but this is rehab for other pulmonary diseases. And essentially you have pulmonologists there, right, as far as I understand. As the burden of TB in the country goes down, then basically to keep jobs for your pulmonologists and to help patients with other pulmonary diseases, then you have created this center, right? Thank you for the question. Well, all the physiatricians, all the TB doctors in Georgia, they have two specializations, both physiatry and the TB doctors and pulmonology. We all have dual specializations, so that is not a problem. As for keeping the jobs for these doctors, well, it's not like that. This is a rehab facility with 100 beds only. And there they employ not only pulmonologists, they essentially have only two pulmonologists there. Mostly it's a place for rehabilitologists. Well, this is the name we use nowadays. Of course, we provide rehabilitation for people with chronic diseases who recovered from acute pulmonological diseases, and patients who complete their chemotherapy after TB. So if patients were cured after TB, but they still have some residual pulmonary inefficiencies. Thank you. That was a very interesting clarification that you had. And now, please, the floor is yours. Thank you so much. I'm a medical coordinator of Médecins Sans Frontières. Thank you for this very interesting presentation and this new information. It really is interesting to hear about these processes and achievements. I would like to ask, what is happening with the cartridges after you have used them? Because this is a matter of environmental protection. How is this organized, the disposal of them? And also, this is a question to experts. Are there any alternatives? Because we all need this test. It's a life-saving test. We understand that. But are there alternatives that would be more, say, environmentally friendly? Thank you. Natalia, I think this is a question to you. So the cartridges after use, they are burnt. They're in both from Zhytomyr and... Can you hear me? It's better if you... So they are disposed, yeah, they're disposed of after use. Incinerated. We sterilize them in autoclaves and then incinerate.
I would like to remind you that our today's first session is dedicated to moving from policies to practice, and we will have time to discuss the technical details later. It's very interesting and important, and I was really pleased to hear this environmental question. Still, I would like to ask to use this rare opportunity. On stage, we have the colleagues who implement very novel treatment and diagnosing methods. I have a question related to pilot trials, pilot project and operational research. Quite a small group of patients who can have access to these novel treatments in Belarus, in Ukraine, in Armenia. Not all the patients in need. Who, if possible, how do you see the future of these shorter all-oral regimens, BPAL regimen? What programmatic barriers do you envisage that have to be eliminated for mass introduction of these innovative methods? I would start saying that I see no barriers, so that all the patients with diagnosed rifampicin-resistant TB without resistance to fluoroquinolones, nothing basically can prevent them from starting shorter regimens. The only barrier, the reason why we enrolled only 300 patients, was because there are not so many of them in Belarus. We have around 900 patients per year in Belarus, and starting December last year, we enroll all the patients with pure, so to speak, MDR TB for shorter regimens. We can't get more patients than we have. And back in 2018, 2019, we didn't do that because it was a pilot project. Now this is the operational research. But at that time, there were not enough drugs for all the patients. Now we have sufficient amount of drugs. We enroll everyone. All the doctors are trained. We can implement active pharmacovigilance in the regions. This covers the whole country. So basically, you implement it on the programmatic basis, right? No, there are some differences. Programmatic implementation is not an operational research. Operational research and the barriers which may arise is an extra load for people who participate in the research, not patients, but the doctors. If we have a 9-month operational research, if it was a programmatic use of shorter regimens, that would mean that the doctors would not to have to complete the special forms, documents, but this is required for organization of the trials, of the studies, and this is an extra load for doctors. And in this case, the barrier is this extra load, at least, which at least in Belarus is not paid for. However, we keep doing that because our doctors are really encouraged with the fact that they may treat patients for 9 months instead of 18 or 20 months. And OR is an additional paper and monitoring load. Extra studies, extra control. And any patient, both in clinical trial or operational research, this is beneficial for patients, and the patients are happy to participate because they have better treatment conditions. They don't need to think about tests. They're monitored for 9 months, and if we have any bonuses, then we, of course, give the advantage to the patients in on the trial. This is good when the country has the capacity for that. And it's good when the country can perform operational research. Yana, you wanted to add something? Yes, I would like to share Ukraine's experience, because until recent time, operational research of new treatment regimens, this was rather an exception in Ukraine. And basically this that was done at the premises of our National TB Institute, and we're grateful to our partners for that, who, when we had certain limitations in the national program, they helped us to move along with other countries. Actually, there were a few limitations. First of all, these initiatives were not systematic, and now it really helps that the WHO gathered all the countries, proposed certain guidance and protocols of research protocols and the plans, including practical assistance. Of course, it's clear it's a big responsibility to implement the regimens which we think are efficient, but still there are a lot of questions and we need to make some additional decisions and studies. That is why this breakthrough of Ukraine is, I already said that, 15 pilot projects throughout the country, and in 20 regions we had very good comprehensive training of the staff. Another limitation was the drugs, because for the operational research, usually the drugs are procured separately, and by the time we get the protocol adapted, persuade the ministry, procure the drugs, the new, more efficient regimens appear, and we're getting late all the time. That's why we took a different way, and we're going to use for the operational research a good quality certified drugs available for the national program as well. Another important thing I wanted to point out is the permission or approval of the ethics committees, because we know this can be an endless process. And in our country, we solve this issue in the following way. In one facility in the Center for Public Health of the Ministry of Health, there are 2 units. One of them coordinates TB treatment program, another unit coordinates operational research, and they have the ethics committee which had international assessment and complies with all requirements. And this eliminates this barrier for us to get the OR protocol as soon as possible. But the main unresolved issue which limits us is that we can't say the new ORs are available for the whole country. First of all, there are programmatic limitations. We have 25 regions. We need to have very strong team and partners to scale up. Secondly is the difference in the regulatory framework for civil and penitentiary sectors. Unfortunately, we still have some regulatory restrictions and the criminal code of Ukraine, which regulates the operation of the penitentiary system, which prohibits medical studies in penitentiary sector. We had discussions with the representatives of the penitentiary sector to advocate changing this in this regulation. These are the main things we wanted. Thank you, Jana. You underlined very well that the operational research requires quite high capacity, especially in a big country like Ukraine. It is hard to enroll all the patients in treatment. I have, yes, who was the first one? I think you were. Thank you very much for invitation, for organization of such a meeting. I represent Uzbekistan. My name is Bakit Marzaliyev. And actually, I've heard the best practices. I've seen the best practices from Georgia, from Ukraine. Yana shared information about the difficulties. We are making just the first steps in terms of introducing modified regimens. We are discussing protocols. There are some experts who were trained in BPAL. This is not an easy way to implement things through operational research. I heard that in some countries, XDR-TB is regarded as an orphan disease. This can be another method of how to bring in the drugs for treatment of orphan diseases without registration. And what challenges did Belarus have in implementing battery must be low? I've seen you modified BPAL regimen. You added clofazimine additionally and reduced the dosage of linezolid. Our doctors understand it, and bearing in mind the experience of using linezolid, the irreversible consequences, very serious consequences. From our side, we welcome this, and we would like you to share your experience and the protocols, Nana, Kira as well. Our experts visited Georgia and Belarus. I hope we'll do it again and learn how to implement that. But the question is, what difficulties did you have, and how did you overcome those difficulties in Belarus and in Georgia? Thank you. You know, we didn't really have such difficulties in Belarus. We never used the regimen with linezolid 1200. That's why we didn't have such difficulties. We used linezolid always from the very beginning. The first patient was back in 2010, and we used at the beginning 600 milligrams. Why? Not because we're so smart or special, but because it was recommended by the WHO, and it is still recommended by WHO, 600 milligrams per day. And Belarus is an example of the country which strictly follows WHO recommendations. And within these recommendations, we never had any deviations at all. So we used linezolid 600, and doesn't matter whether it is shorter or longer regimen. Longer regimen and for after 8 months of use, the dosage was reduced to 300 milligrams for each patient. And when there was an initiative to use higher dose, we didn't take it, we didn't accept it, because we had an experience by that time that the dose exceeding 600 milligrams can hardly be tolerable. And I agree with you that even doctors who use 600 milligrams, they know it very well. This is the maximum dosage for routine use. Maybe there are some other cases, but in general, it's like that. And with regard to importation of drugs in the country, we're lucky to have the representative, Svetlana Kazimirova from our expert and trial center. They helped us every time, and we use this one-time importation system, both for programmatic use, like bedaquiline or delamanid, which were not registered in the country. Now only bedaquiline is registered in the country, but not delamanid. We have this one-time importation and registration procedure. Maybe I call it a bit not very correctly, but we never had the problem. We had it only for the first time to bring in bedaquiline back in 2015 because that was the first experience. Now everything has been worked out. The expert center revises the documents and gives us permission to import the TB drugs. I think with predominid, the situation was the same. So these are not programmatic barriers. Our main difficulty we still have is that operational research, unlike clinical trials, are carried out by the personnel free of charge. So the personnel is not paid for that, and this is the major difficulty. We all know that in clinical trials, those who participate are additionally paid. They have quite good payment compared to our salaries. That's why people are eager to do that. Operational research is like, let's do it to help our patients, but in principle, for our country, it works. But still, it is a certain difficulty, because when you know that a doctor is paid additionally for that, then it is easier to ask this doctor for results, and it goes in a smoother way. Anyway, we're coping with that, and I think if there are representatives of the Global Fund here for the next round of grant, you may to ask funds for operational research, but I hope that we will be supported. We're not asking for that anyway. Now we have 300 people. Part of them have completed treatment, and it shows us that shorter regimens are efficient, and we can see how much money we can save, even for drugs, also for inpatient treatment, for outpatient treatment, and part of this money can be given to the staff who takes part in the operational research. Thank you. Regarding registration of TB drugs in Georgia, they're not registered in Georgia, but we have very flexible legislation. We have no barriers to import the drugs. Georgia procures drugs. 80% of drugs are procured by the country, 20% by the Global Fund, but we procure drugs through GDF. That is why the quality of those drugs is guaranteed. As far as implementation of new recommendations is concerned, I think the main the main thing is the support of the ministry and of the authorities. I'm proud to say that in Georgia, it is, if something new appears, this always gets the support from the part of the authorities. And we can, in a very short period of time, we can implement everything recommended by the WHO. Now we have a new minister, but the first deputy minister, Tamara Gaponia, and many of you know her. She's been involved in TB control for many years. She knows everything about TB, and she supports us actively. I would like to say briefly, to give you an example of how to eliminate TB in the country. In 1996, I will tell absolute numbers. When we started our program, we had 12,800 registered cases. Today, we have 2,647 patients. This is for the end of 2019. Every year, the number of AMDR TB reduces. And last year, we enrolled in treatment less than 300 patients with rifampicin-resistant TB. And 2 years after, we had in total 700 patients per year. We have very good results. And you remember I showed you the results of clinical trials. We did it in such a way that all the doctors involved in MDR-TB control participated in clinical trials. And from their experience, they proved that these regimens, mostly oral and shorter regimens, they're very effective. I can say we had a clinical trial, Xenix, which means BPAL regimens, which includes BPAL regimens. And you can believe me, I can tell you that patients with XDR-TB and with diffuse parenchyma lesions had very good outcomes, both from microbiological point of view as well as clinical. And I'd like to add 2 more words about linezolid. Now, many people say linezolid in the dose in 900 and 1200 milligrams, the dose is very high. But in Georgia, there's a very good article of our doctors, together with which proved that in the concentration and tolerance to linezolid, a very big importance is related to regional and genetic features. In Georgia, people tolerate very well 600, 900, and even 1200 milligrams. We had only 2 cases when some people had not very serious adverse events, myelosuppression. But in general, linezolid is tolerated quite well. Thank you very much. Actually, sometimes I have to. It's very interesting what you're saying, and if we had a clinical conference, we would be happy to spend more time to discuss this. Just a second. We had a queue of Naira will say a few words, then Faud. Well, I have not a question, but a short comment. I can do it. I can make it in the end. You know, we have a relatively small country, and the number of patients is low. Now we're starting the operational research of shorter regimens. In total, we have estimated number of 67 patients that can be enrolled in this research. So the cohort is so small that there are no obstacles for that. And I also want to add, when we updated our protocols, we updated all the forms for TB patients management. All these forms are almost identical to those used in the operational research. There are some differences, and the doctors should manage patients the way they manage the other patients. And for us, this is the kind of a good approach to address possible issues. With regard to drugs, we also have no problems. We receive all the drugs. There are some patients who can use the same regimens but for longer time. This is all I wanted to say. Thank you, Naira. We have a question from our colleague from India, then Khachatur, then Gabriela. We will accumulate the questions and answer them all in one.
Enlightening us. I have a small question. Rehabilitation center that you mentioned, madam, is it a standalone rehabilitation center or is a part of hospital? Because what I understand, all these rehabilitating patients may require some emergency services if they become worse during exercise and physiotherapy.
Thank you for the question, Khachatur. Thank you for the presentation. My name is Khachatur Malakian. I represent Médecins Sans Frontières in Ukraine. All presentations were very interesting, and I would like to go back to the subject of this session, and in particular, the slide number 1 presented by my colleague Oscar regarding gaps in the countries. And if I'm not mistaken, this was related to the goals set to all the countries in our region to reach them by 2023, which means we have 3 years left, right? And such huge gaps, and how our countries are going to close those gaps during 3 years. I can see that there is an additional comment to the previous discussions. Yes, operational research is a good start, but it's not a long-term solution. And if the country is big, it cannot cover the whole country. This is not the question, this is the comment. And I wanted to ask the countries who can tell us if they're ready to close that big gap within 3 years. If there are such countries, I would be happy to listen to them. Thank you.
Hi, MSFTB advisor. So I have a slightly provocative question, which is, do we really need operational research and in all contexts? Maybe because I'm based in South Africa, we know that the new oral short regimen comes also from a model of implementation rather than strict operational research that has contributed to policy change. So although your experiences are fantastic, really congratulations to all, but we know, maybe in Belarus less, because it really seems a broad scale up, but we know that operational research comes with some delay and inclusion criteria, often population, the most vulnerable ones, the children, the pregnant, the prisoners, they are excluded. How can we provide access while building evidence? Absolutely, I'm not against that. And so it's a little bit to hear from you. Do you think that this is the only model to go for oral modified regimens that are beyond the currently recommended ones?
Thank you, and we have time to take one more question. Thank you to the presenters. I have a question. Alena has mentioned that in Belarus the patients have no doubts regarding the beginning of the operational study. What is the situation in other countries? Are there barriers at the patient level? If there are, how you overcome them, and is there a need to cooperate with the civil society? Thank you. So the first question on the rehab center in Georgia, can you provide emergency care there? So it's not a hospital. No, it's not a hospital. Inaudible. So if we have emergencies, there's ambulance. No, we do have a special ward. We do have some equipment, so we can provide urgent care. But, well, treating and continuing treatment there, well, of course, we don't have any means for that. Question number 2 was on 3-year gaps and how countries will manage the closure of the gaps from 2020 till 2023. Well, the question. So we have 3 years left until 2022, and the gap is serious indeed. Of course, it's difficult to find an easy solution. We do understand this. We understand that non-governmental investments in this issue, well, will not be enough to reach a lot. These are only some milestones that help us advance to the target which we have by 2030. That will be a tipping point, really. Now we simply deal with what we have. And yeah, once again, we encourage all the countries to think. If there's no external assistance, what do? We can't just leave things as such. We have to find the internal resources. We have to find resources inside the countries. How do we do it? We do have ideas. We do have some proposals. And I encourage all the countries to start thinking about this. And we can help. We have our own ideas and developments. As I said in my presentation, we even have some resource figures, like how much resource is needed in every country. There are models which can be built with our partner, Winner Health, that help us model things for prevention, for treatment targets, resource targets. All is there, all is available. So, there is some ongoing work on this. Even the Global Fund is thinking how this can be done, because they can't just leave a country, leaving them basically at nothing. So, there are some things, and some countries start piloting this, for example, with insurance, with medical insurance. And yeah, when you mentioned operational studies, this is where we can do studies, how this can be improved. Inaudible. Yeah, this is some kind of electronic virus, I think, infecting our microphones. Yeah, by the way, talking about viruses, recently the World Bank has announced their readiness to fight COVID using $12 billion US. The United States is ready to offer $8.5 billion US to fight the virus. What was the work conducted by the global? So remember how much work was done by the Global Fund and all the others to replenish the Global Fund, and we've collected $14.2 billion. So the humanity. You see what the humanity is ready to do to overcome only one particular disease. So if that is possible, then also overcoming our gap is also possible. The resource is there, we just have to find it, or even the resources inside of these countries. It's just, how is this going to be done? What are the mechanisms for this? Advocacy tools. We have to really apply it thoroughly and everywhere. And the communities play a crucial role in this, because their voice will be heard the most. Their voice must be addressed to everyone, because their voice will get there faster. So in terms of the gap, of course, we have to look at overcoming it in partnership with communities. Yeah. You said that it's possible to find internal resources inside the countries, but we see, well, it's not always possible in every country. So we still have hopes on international assistance. So we don't want this message that it's always possible to find internal resources. We don't want this message to dominate in the discussion. Well, states have promised to do that already. They have signed the declaration. The states have already promised, so it is an obligation of them. Yes, of course, but we know about the gap between the declarations and the implementations, right? There's another interesting thing. The question on the gap, the question on what is preventing us in achieving our goals, it's global. And in terms of diagnostics, well, we know that we do not see many patients. We don't find them. Can you share any country examples. I mean, how do you plan to find these patients? Should you actively engage primary care, where we still see difficulties in many countries in engaging primary care for TB finding? So what if we bring MDR TB treatment for primary care and then we stop DOT, which takes a lot of resource also? But, well, this is a topic for our next session. Oh, as a lab specialist, I can't say anything about DOT, but I want to say that we have to separate diagnostics into pre-analytics, analytics, and post-analytics. So pre-analytics, which we do, is a new case finding. This is working with contacts, this is working with risk groups, this is active, well, as we say, field work. In Ukraine, as of today, all the labs have underwent external quality control, so we can say that if we get quality samples, the labs will detect and they will test for resistance. So I think the most work has been done out there, in the risk groups, in the key populations, finding the cases. Thank you. I would like to merge the questions of Gabriela and Julia, because both questions were on operational studies. On the previous one, right? Yeah. No, on this one. Okay. Yeah. Let's give the floor to you. Yeah. In general, what I wanted to say, my comment essentially merges very well with the question asked by Gabriela. I would like just to note the fact that now, and many have noticed, that in TB programs we see the trend. We are in this epoch when TB treatment is changing drastically. We have new drugs, we have innovations in diagnostics and treatment. That is why things that are done, for example, in these countries, which we've heard in presentations, and this is a new, more dynamic implementation of these innovations. So operational studies, to implement it as fast as possible, this is how we can do. And we also should remember that in operational studies and in randomized clinical trials, so besides advantages, there are also risks, inherent risks. That is why we should still be responsible. So we shouldn't probably jump over certain stages in trials. We know that new approaches bring sometimes new risks. But if we apply this new dynamic approach and trying to implement things faster, well, we always mention barriers here. But there are methods to ease this transition from the trial stage, operational studies, to actually program implementation. And these methods to overcome the barriers are the following. You need to document very well everything that is happening in operational studies. You need to do it in a more or less standard format to simplify the data collection, data merger. I approach to this as a proponent of the evidence-based medicine and things that are done by the WHO. Then this data will be easily used to develop new recommendations and new guidelines. So I encourage you all, do the operational studies, but develop proper data collection so that then it will be used for evidence and then it will be used for guideline development and program implementation. Because the guidelines now are essential to bring new approaches to programs. Thank you. We all understand the benefit of operational studies. That is a very important stage in the implementation. Nevertheless, they hardly can provide access to treatment to all the patients who require it. And I presume the question of Gabriela was related to the fact that very often we do run a lot of operational studies without any kind of a critical endpoint. I mean program endpoint, not study endpoint, that would help us easily switch from the study to program implementation. Yulia has asked a very important question, that operational studies is not only about evidence, this is also about patients who can experience certain barriers for inclusion, either from the side of the system or from the side of the patients. Yeah, and operational studies are usually more centralized than program use. So perhaps that also is another important topic that the colleagues tried to explain. You have provided your response, but we don't have time for this discussion, and we have already highlighted main things, but maybe still 2 or 3 words if anyone wants to comment. So, I mean, regarding operational studies, how long should they go before we can move to program implementation? Belarusian experience is very important, but this is kind of unique. Not any country can afford that. And also the patient question. If I may, I would like to add about the patients and operational studies. I didn't want to, I didn't mean that Belarus is a country where it's very easy to run the operational study and other countries have a more difficult situation. No, I just said that it can be done and I'm confident that it must be done. It was for the first time in August 2018 when, as part of urgent notification procedure, the World Health Organization started encouraging countries to do operational studies. Why is the WHO doing that? I think Fuat might correct me if I'm wrong, but I'm sure that this actually is the faster way to develop new WHO guidelines, because they must be done on the basis of evidence data. So, if we simply implement things programmatically, this might have some negative aspects. For example, we might not register some adverse effects, we might have really some risks, and we don't document it properly as part of clinical trials or operational studies. You know that there are about 10 regimens that are now introduced as clinical trials of shorter regimens. And NICS was over in 2019. Others will be over in 2021. One of those, yeah, or even later, they will be over, like the first will be over in 2021, some will be over later, then it takes time to analyze and to develop new guidelines. So as I understand, the WHO enables us, with these operational studies, to collect proper scientific data faster, so that they will be faster analyzed, faster published, and the guidelines will be developed faster. And it's not only about the guidelines. When we do this as operational study, we also get our own confidence that these regimens are effective and safe. I do believe WHO guidelines. You know, they are like second book after Bible for me. And nevertheless, when it is your own data, you are even more confident. It's very good. And there's no other way. I don't see any other way. I think these processes should go in parallel. We do follow WHO recommendations. We learn how to manage the patients, we get new knowledge, and the patients only benefit from this. As for obstacles and barriers for patients, yeah, it is a wider question. Well, in our country, we don't even have barriers. We have to convince patients to enroll into the study. The only barrier is the informed consent form that must be signed. This is a barrier for some of the patients, indeed. In our country, this is a barrier for patients in prisons. Nevertheless, out of 25 patients, 24 have signed. Only one didn't sign. But other countries might have a different experience. Thank you. We are essentially out of time. We are now deducting from our lunchtime. I would like to note one more thing. I'm sure that we all in this room, we have great estimation to WHO guidelines, and I would like to note that there are other ways, that there is experience of South Africa. They are really advancing. Without waiting for WHO guidelines, they had a quite a revolutionary approach, implementing all oral regimens. That is this other path that can be done. Because operational studies are good, but at some moment we have to think about programmatic implementation. I would like to say thanks to all the participants of this discussion. We did manage to set the tone to this symposium. We will get back at 2 p.m. At 2 p.m. sharp. Lunch is... Alex, will you guide us to lunch? And thanks to everyone.
Уважаемые коллеги, одно небольшое организация.
Dear colleagues, just a short organizational announcement. Probably some of our guests has lost his Huawei telephone on the sofa in the lobby. If somebody discovers absence of this phone, it is at the reception, or otherwise you can come up to me. Have you checked your mobile phones?
There is an announcement that someone might have lost the phone, Huawei. So in case if it's one of you, please approach come to the reception. Thank you. Now, welcome back everyone. I hope you had a good lunch. Let's get started with this afternoon session, which is all about empowering the patients, making sure that they are informed and in control of their treatment. As we know, this approach is brings the best treatment outcomes. Like last time, this will be followed by a panel discussion chaired by Gabriela Ferlazzo from MSF's Southern African Medical Unit and Julia Kalancha, Advocacy and Policy Manager for the TB Europe Coalition. Welcome to the presenters and cheers.
Hello everyone, welcome to the second session. And it's the second, I will speak in English because most of our speakers, they will be speaking in English, so not to make any confusion, I will speak in English as well. We are now opening the second session with the topic empowering patients to prevent and defeat TB. And this topic within this session, we will discuss very hot topics related to DOT issues, importance of people-centered approach, the use of different tools to increase the treatment outcomes, and transition to oral regimes. So I would like to present our first speaker, Dr. Jonathan Stilo, who was not able to join us today in person, but we have a video presentation from him, and through this video presentation, he will try to answer not an easy question: do we really do DOT, and should we? So Dr. Jonathan Stilo is an assistant professor of medical anthropology in Wayne State University and the co-chair of TB Europe Coalition, and with more than 10 years of experience in TB. And his current work focuses on social, economic, and structural barrier to health, and how better outcomes can be achieved through a human rights-based approach and people-centered approach. So let's see the video from Jonathan Stilo.
Hello everyone, my name is Jonathan Stilo, and I'm an assistant professor of medical anthropology at Wayne State University in the USA, and I'm also the co-chair of TB Europe Coalition, but I'll be speaking in my personal capacity today. Thank you so much for including me in the symposia, even though I wasn't able to be there in person. I really appreciate it, and I wish I could be there with you. What I'm going to be discussing today is the evidence around directly observed therapy and whether we're actually doing it as described, as well as some human rights and patient-centered concerns surrounding it. Now, it's important that we clear up some terminology. When I'm speaking about direct observation or directly observed therapy, what I'm referring to is a person being observed taking their pills by someone or some device. That differs greatly from the WHO NTB strategy and the ethical guidance for the implementation of the NTB strategy. And both of these documents require that care be patient-centered, and they favor multiple options not limited to observed treatment, and also stress the need for economic, social, and psychological support. And the ethical guidance states that if DOT is used, it should be available at a location of one's choice, and it should be provided by a supporter of one's choice. And it's also important to note that the costs associated with treatment, such as transport and lost wages due to having to go to a treatment site, should not be borne by the patient. This is one possible way of creating additional economic burden, and that's something that we want to avoid. And it's baked into the WHO strategy. However, more or less, it's not what's always happening on the ground. We've been using DOT against TB for about 60 years now, and the initial data for using this approach comes from the Madras study in India, as well as research conducted in Hong Kong in 1959 and the 1960s. The aim was to have cost-effective treatment that could increase people's adherence. Prior to this, TB was mainly treated in hospitals and specialized sanatoria, and it was on an inpatient basis. Initially, the debate was, should people be hospitalized for the full duration of their treatment, or can they receive treatment in the community using DOT? Now the discussion is around whether there is a need for DOT at all. Now, it's important to note that DOT is not widely used under programmatic conditions for any other disease, including HIV. This is something that's strictly done in the TB world. Another important question is whether we're doing direct observation as described. Many studies, as well as WHO program reviews and Green Light Committee reports, show that direct observation is not happening as described, especially in rural areas. A good example of this is Ben Baba et al., which is looking at the MSF site in Mumbai. And they found that there was a pretty wide difference between the descriptions of DOT that were coming from providers versus what patients were reporting their actual conditions of DOT were. And this is also similar to what was found in Romania during the TB program review. And I can attest to the situation in Romania. I've worked there for nearly 20 years now, and specifically on TB for over 14. And Romania has announced that there was 100% DOTS coverage since at least 2006. However, the TB program announced in 2013 that in rural areas where actually almost half of Romanians lived, that even dispensary or family doctor-based DOT was not possible due to health system limitations. Now, this doesn't mean that the quality of care was bad. In fact, I witnessed very comprehensive explanations that doctors were providing as they handed the patient a large plastic bag full of their medicines to take back home in their village, because they simply were unable to drive into the city to have DOT as the program allowed. And the program had no means of providing in-home or even local DOT in this large county, which was mountainous and had many villages. Another important thing to consider is whether DOT places a burden or can even cause harm to patients and their families. Generally, direct and indirect costs are borne by patients and their families, and these include transportation, as well as time off from work. And this is especially important for people involved in agriculture, which has very strict seasonal requirements, as well as those who do day labor and the types of work that don't allow them to seek treatment in a dispensary. And another important thing to be sure we discuss is the burden that is placed on caregivers of small children and older adults. And this is largely borne by women, and that can interfere with their ability to take DOT at a clinic or dispensary at set times. DOT is quite expensive to health systems, and it can be a challenge to provide in rural areas, like many of the countries in the WHO Euro region have. And finally, even efforts to reach people in outlying rural areas may be stigmatizing. For example, if the treatment center staff show up in an identifiable vehicle, for example, that says this was a gift from the American people, if it was paid for by USAID, or this was provided by the Global Fund, that identifies people as being, as having a disease which in their community may be stigmatizing, and their friends and neighbors may not know about it. So in our efforts to make care more accessible, we could unwillingly do harm, and that's also a potential problem. So recently we've seen many technological solutions aimed at solving the problem of how to reach everyone with directly observed treatment. And these include smart pill boxes, blister packs which have cell phone codes on them, wirelessly observed treatment where one ingests a sensor and then that sensor reports whether or not they've taken their medicines, as well as slowly dissolving coils of pills where an entire treatment course can be placed into a patient at a single time. Now, it's important when we're thinking about these to note that they're not magic bullets, and they may be appropriate for some people, but they likely won't be appropriate for all people. So they're tools rather than magical solutions. They're things which could be incorporated into TB programs, but only if they're appropriate for that particular patient. None of these is going to be universally useful. So what does the evidence on DOT actually say? And in general, it's weak and sometimes contradictory. There have been multiple systematic reviews and meta-analyses that show no clear benefit from DOT versus self-administered treatment for both active and latent TB. There was a systematic review of community-based DOT that did show a benefit over self-administered treatment, but I note here that community-based DOT is not what we're seeing in many places in the WHO Euro region. Clinic-based DOT and family doctor-based DOT are much more common. We do have strong data showing that economic, social, and psychological support increase adherence. And sometimes these are delivered as part of DOT, but they're separate interventions unto themselves. And they oftentimes are not part of the DOT that a TB program is providing. WHO recommendations prefer community-based DOT over health facility DOT, and they prefer observation by trained workers over family observation or self-administered treatment. However, the quality of evidence that this recommendation is based on is quite low, and as I mentioned earlier, there's a strong body of evidence showing that there's no benefit whatsoever to DOT. Here's a list of some human rights and ethical concerns connected to DOT, and this is an incomplete list. I'll just highlight a few of them. Some of the new technologies around DOT, such as wirelessly observed treatment and video observed treatment, introduce some privacy concerns that we have to be attentive to. There's also the question of dignity. Do patients feel like they're being supported, or do they feel like this is more about surveilling them? And if that's the case, then this can hinder the building of trust between them and their doctors. There's also the question of health accessibility. If people are paying money for transport and lost wages in order to seek out DOT, then it may be that some of the poorest people are not able to access treatment. The right to work may be infringed on due to the limitations in the time when DOT is available, as well as the right to education. So in conclusion, I want to summarize some of what I said earlier. The evidence base for directly observed therapy is weak, and recent research suggests that it doesn't provide an adherence or outcome benefit. DOT is based in the historical mistrust of people with TB, at least in part. We have to remember that TB is a social disease and has long been associated with poor, vulnerable, stigmatized populations. We also have to remember that DOT is already not happening for many people with TB. That clinic and hospital-based DOT that most people receive in the WHO Euro region is not patient-centered and may be an economic burden for them. We also have to note that adherence technologies like video observed treatment and wirelessly observed treatment are tools. They may be appropriate for some, but they're not magic bullets, and they also come with some additional human rights concerns. Now, finally, I think now is the time that we need to talk about what does work and to promote strategies that are patient-centered, evidence-based, and that respect human rights. Minimally, that will require some flexibility and the ability of TB programs to offer somewhat of a menu of options of types of support, as well as observation if it's appropriate, as determined by the patient in collaboration with their doctor. Thank you so much for your time.
I start by saying dobry večer. I hope I pronounced right. Good afternoon. So if Dr. Stiller was here, I'm sure there would already be a lot of questions. But I think to summarize, and we will have more time for discussion later, as also some other presentations will touch on this subject, it seems that we are moving a long way from thinking that DOT, and especially health facility DOT, was the solution to patient adherence, to control patients, and now we are realizing, and there is growing evidence around that, that it's not. So with that, I would like to introduce our next speaker. I'm very happy to have here Dr. Parvati Nair. Dr. Parvati, she's a physician with expertise in drug-resistant TB. I had the pleasure to meet her in Mumbai, where she was working in a DRTB project. And now she's working the Uzbekistan project with MSF. And she's passionate about providing early diagnosis and treatment through a patient-centered model of care. So Dr. Parvati will present today on short course regimen qualitative study and link to person-centered care.
Thank you, Gabriela. Здравствуйте. I have the fun job of presenting after lunch, so I'm going to try to keep it short. So what this is a qualitative study on the short course regimen and with a link to person-centered care. The authors are Shona and the various people from the Ministry of Health. Dr. Parpiva, Dr. Zanaida, who's here, and Medco, Dr. Jazinder Singh. The background and aim of this study, patient-centered care, or rather person-centered care, is an internationally recognized priority describing the involvement of people in their care and treatment decisions and the consideration of their needs and priorities within service delivery. The patient voice, experience, and perspective relating to short course regimens was lacking, which is why we thought of doing this study. The aim of the study is to examine the views and experiences of patients with MDR-TB and practitioners regarding the short course regimen in Karakalpakstan, Uzbekistan, to inform patient management policy and practice related to the implementation of the short course regimen. So the methods of data collection and analysis. Purpose of sampling, including those best able to provide insight to the topic of inquiry. The recruitment continued until evidence of data saturation, that is when adding participants did not generate any new findings. 48 in-depth interviews were done and data was analyzed thematically to identify emergent patterns, concepts, and categories from participant accounts. It aimed to identify findings inductively, reflecting patient perspectives and experiences as closely as possible, rather than testing predetermined hypotheses. So we had a total of 20 healthcare workers, 11 doctors, nurses were 5, and counselors were 4. 12 of them were from the Ministry of Health and 8 from MSF. The participant information, we had 24 patients. The ratio women to men was 12:12. About 8 of them were from the 18 to 24 age group, 9 from 25 to 34, 2 from 35 to 44, and age 45 to 58, there were 5. Treatment category, 15 of them were on the treatment, 5 were completed or cured, 3 were failed the treatment. There were no lost to follow-up patients in this, but that's because it was not possible to recruit people who were lost to follow-up. 2 were not accessible, 3 were uncontactable, and 1 was no-show. There was 1 relapse, and 4 were transferred to the standard regimen. So, these are the factors affecting patient engagement with care in general. So, the ones which supported engagement were when the symptoms didn't improve, so they understood they were sick, and so they wanted to access care. Family influence, if the family supported them towards it. Screening, so as part of screening for military or for the health card, they realized they had TB. Along the treatment taking journey, if they accepted their diagnosis and were ready for treatment, it supported engagement. And they also that they perceived that they needed the treatment. Evidence of treatment effectiveness. So as their symptoms reduced, as they started feeling better, they began to understand that, okay, maybe this treatment is working for me, and that further supported their engagement. It was also important to have a hope and belief in cure and support, whether it be from the family or from the counselors and healthcare workers. Another strategy was distractions from treatment. which was different strategies which were maybe, given by the healthcare workers, like breathing exercises, meditation, hope for the future, and helping them plan for the future. And for people who had small children, thinking of their children and what they would do if they were not there. Factors which negatively affected access to care was, some of them just think that TB is a cold. So they say they had ice cream, or they went out and they were sweating and they came back and they had a shower and it was cold, and after that they developed TB. Some of them had no real signs and symptoms of TB, and so they didn't really understand that they had TB. Low health literacy, where they did not understand what was happening with them, was also something which affected their access to care, because I guess they didn't understand that they had TB. Stigma, as everyone knows, is a huge thing. When people feel that they are isolated from their friends and family, when people feel that they're isolated from their friends and family, then they don't really want to engage with care. And beliefs about TB etiology and transmission, they don't understand how they've got it and why they've got it, and they don't perceive the risk, and therefore they don't want to access care. Factors which affected the treatment taking journey. So people who, well, your job and the fact that you have to provide for your family will always affect the journey. So especially when you have dots, and that affects your life in general. That's one of the reasons why it undermines their engagement. And also if children who couldn't go to school. Treatment fatigue. You have some people who have been on treatment for a number of years and have got multiple treatments, and they really don't want to take treatment anymore. Some of them, of course, developed aversions to drugs. Very often, it's drugs like prothionamide, from what we see, and the side effects of the drugs make them not want to take medication in any way. And treatment intolerance. So some of them seem to think that, that it was their mind which was more responsible for why they were having issues with the TB medications, and they thought that they weren't strong enough mentally. So the views about the short course regimen. Of course, the good things were it's a quicker return to normal life with the short course regimen. 9 months versus 24 months. That's an easy one. They want a relapse-free cure with effective regimen, but the priority was reduced pill burden. It's a shorter treatment which increases mental health and it decreases stigma or burden. But the healthcare workers' views were a little different. Some of them had more confidence in the longer regimens because basically they've been working with that for many years. Others also wondered about the length, 9 months versus 24 months, and the fact that they were using drugs which the patients were supposedly resistant to, for example, high-dose isoniazid. There were concerns about the appropriateness of putting the patient on treatment and the inflexibility of the short course regimen, in as much as if the patient develops side effects, then it becomes a little difficult to modify the regimen. But the good thing about it is that they all understood that it enabled adherence and retention in care. So, factors which favored person-centered care. Clarities around expectation and treatment readiness. Patients want to be involved in the discussion. It was important to help the patient to decide what treatment location they wanted, whether it was ambulatory or hospital-based. Peer-to-peer information where someone who had actually gone through the treatment gave information was valuable. And there was the importance of information and understanding, which increased ownership. The factors which undermined it were unfamiliarity with the concept of shared decision-making. They expected the doctors to make the decision for them. DOT potentially undermines responsibility for treatment because then the patient doesn't think that they need to take the treatment. They're going to the doctors or the nurses, and they were the ones who were taking the responsibility. Misinformation also undermines engagement and trust. So conclusions. The benefits of shorter treatment, enabling quicker return to normality, reducing the burden of treatment, including stigma and mental health, and supporting adherence. Healthcare workers have concerns about short course regimen effectiveness and appropriateness, which may influence who is offered the treatment. Person-centered care could be achieved through dialogue, information, understanding, supporting patient readiness for treatment and sense of ownership over health and treatment taking. So you have the various comments from the different patients. One person wants to be cured quickly and start work. Another person says, it's my life and I want to know what's happening. And you also had the healthcare workers who said that even if the patient matched the inclusion criteria, they're not very happy about putting the patient on short-course regimen because they're worried about future intolerance. So the recommendations which come out from this. As regards patient support towards TB acceptance and treatment readiness, examples would be information support and visual aids. During first 2 months of treatment, which are particularly difficult, conversations in dot corner, reassurance for cure, encouragement and relationship. This could be with the nurses or the counselors. To maintain motivation later in treatment, offering evidence of treatment effect, peer support and information. Positive mindset, hope, distractions and plans post-treatment, and support for the impact on daily life, and support to navigate stigma. So you have visualization tools, economic and psychological support, and strategies to overcome isolation and navigate differential treatment. Healthcare worker support to increase confidence in short-course regimen, to translate short-course knowledge into practice and increase familiarity with short-course results. So for this, it's important that you have membership and dialogues, discussions which address concerns and showcase short-course regimen pilot results and outcomes, and training for all doctors, because it's not just the TB doctors. Person-centered care, increase information and understanding, encourage patients' choice for location, and foster trust within practitioner-patient relationships. Consider alternative approaches to DOT, which could be family DOT, video DOT, and open communication, sharing changes in result or treatment length. In the community, we definitely need to raise awareness about TB through information about the disease and treatment and transmission, and address fears around contagion and blame for disease stemming from not taking care of oneself. There would be different strategies for that, maybe a play, maybe radio, maybe TV shows. Thank you. I've gone a little over time, I'm sorry.
Indeed, people-centered approach empowers people with TB, and this approach makes people responsible for their own life and for their own health, and give them the ultimate choice on the treatment they need to take. So thank you very much, and I would like to present our next speaker, Marvi Duque. Marvi joined MSF in 2010 and works in the area of TB, HIV, and hepatitis C, and is currently working as a project medical reference for MSF in Zhytomyr in Ukraine. And the project is focused on including new and repurposed drugs for treatment of the RTB, and as well is implementing operational research using the same drugs or a shorter duration. And Mari will make a presentation on psychosocial support for patients with DRTB in ambulatory setting. Thank you.
Thank you, Yulia. On behalf of our partners, our MSF colleagues, and the patients of Zhytomyr, I'm happy to present to you our experience in supporting DRTB patients in the Oblast. So the work officially started in April of 2018 after the signing of the MOU among all of the institutions that were involved in this project. And thereafter, we put the first patient on treatment in June of 2018. Back then, we still gave the Bangladesh regimen in our effort to provide a choice to a shorter regimen, albeit it still contained an injectable agent. Let me walk you through the healthcare delivery for patients with TB. So first, the patients are presumed to have TB and are screened for TB in the primary healthcare units. Thereafter, they are referred to the TB dispensary where the definitive diagnosis and prescription of regimens are done. They have to stay in the hospital for quite a while until they are non-infectious or until they are clinically stable, and then they go back to the TB cabinets and the primary health care units, such as the Felcher and ambulatory points, or the different ambulatories in their villages. So we will focus in the project's work in the ambulatory care setting, so in the secondary health ambulatory and in the primary health ambulatory care. When we started work, we tried to look at how provision of care actually happens in the ambulatory care setting. And from June of 2018 until September of 2019, we visited 68 facilities. And here, the findings of this assessment we actually presented in last year's symposium and in last year's union conference. And here we found out that the ambulatory care setting in Zhytomyr is not fully prepared to provide holistic DRTB care to patients. In summary, human resources are there. There are doctors, there are nurses and felchers, but the knowledge and the skills need upgrading. Access is not 100% available. Some TB cabinets are difficult to access. And DOT, although it is a part of the regulation of Ukraine as a treatment strategy for TB patients, was not available in all of the health facilities. Psychosocial services were very inconsistent. So what we do, we try to provide psychiatric services the best we can with the limited resources we have, so through all of these components, as well as provide social service in the forms of food parcels, hygiene kits, transportation and medicine reimbursements, and other necessary help so that the patients can get documentations like pensions. In all levels of care, we provide counseling, which is very important. And this gives us a solid background of the patient's consequences and the patient's needs in order to have a good quality of life, not only to finish TB treatment, but to actually go back to his normal life. And we follow a protocol that stipulates how often, what kind of counseling the patient needs, who sees the patients, what is the referral pathway. So having said all of that, in the ambulatory treatment, when we followed 110 patients, not everyone was able to go through DOT. Actually, more than half of the patients had to go through a different treatment strategy. So some patients were on video DOT, some patients had to go on self-administered treatment, which is not ideal in Ukraine, but is actually a reality for most of our patients. But looking at outcomes, I would say that it was very good. We had no loss to follow-up. 18 patients, 32% have already finished treatment successfully, and 37 or 66% are still in the good track of treatment. So in conclusion, based on our experience, we say that psychosocial support is really a key component of treatment, and that the strategy of treatment should actually be based on the capacities of the healthcare system, but more importantly, on the circumstances of the patient, and the patient's right to choose. Thank you.
Thank you, Marve, for this fantastic experience that you shared. And among the many interesting things in terms of approach and patient-centered care, you touched also on a very important point on ambulatory care and what is needed to implement and to move to practice with this important policy. So maybe we can discuss more about this later. And now we move to the next speaker. It's a pleasure to introduce Dr. Jennifer Furin. I'm sure most of you know Jennifer. She's an infectious disease and a physician and medical anthropologist with more than 25 years of experience in drug-resistant TB across the globe and especially in this region. And she's currently a lecturer at Harvard Medical School, and Jen will present on a key topic, which also reminds us the previous session, which is making the switch, saving more lives with optimal treatment for drug-resistant TB. Thank you.
Thank you so much, Gabriella, for the kind introduction. And I have to say what a pleasure and a privilege it is to be in this room. I look around and I see people who I've known and had the great privilege of working on DRTB with for more than 10 years. And it's very humbling to be with you all, and really amazing to see the achievements that have been made in the region where you face significant challenges. So I know it's the afternoon, and I was struck this morning that this is the 9th such symposium, which is incredible. But I think sometimes, you know, the agendas are always packed full of speakers and there's a lot of information. But I want us to pause and appreciate really the significance of this event. Not just for those of us who are here, but for the very people who face the biggest challenges and burdens living with drug-resistant TB when you go back to your country. And it used to be, I've been an MDR doctor for 25 years, so I know how bad things can be. And it's actually a very exciting time to be in the practice of drug-resistant TB, but not if all of the people living with the disease who come to us seeking help can't access the innovations. And so I'm hoping that everyone will leave this symposium with a real heart for change. I know the barriers are significant. Listening to people talk about the many challenges you have to overcome, it's a daunting amount of work. But the men and the women and the children and the families who come to us at a very difficult moment in their lives deserve nothing better than our all-out enthusiasm and efforts to make sure they get the best possible care. So I put this slide up there because I also think we need to contextualize when we talk about these new drugs and the new regimens and building an evidence base. We need to do that. But everyone needs to be aware that the older, injectable containing and longer regimens that majority of patients in your countries are receiving have never been studied in randomized controlled trials, except as the control arm in the STREAM study. Okay, most of them do not have a registered indication for treating tuberculosis. Okay, they're a high pill burden, they're very toxic. Okay, and when we talk about needing more evidence, it is very true. But we cannot forget where we're coming from, which is no evidence base, the use of highly toxic medications with a long pill burden and very limited treatment success. So we have to ask ourselves, why do we want to keep those old practices? Why do we want to keep the old way of doing things? And why are we so cautious to move towards things that do have an evidence base, that are safer, that are more effective? Okay. The other thing I wanted to mention is that Marvi touched on this and other speakers have as well. We have done a great disservice to people living with drug-resistant TB by relying on DOT. Okay, Jonathan touched on this in his talk, but we haven't formed the important relationships that we need to with people who are living with the disease. And you know, us doctors, we like to use clinical language. We get used to using certain terms like cases. Okay, these terms are wrong and we have to stop using them. We are working with people who happen to have tuberculosis and drug-resistant tuberculosis. And when we use words like cases, it distances us from the people who are our strongest and best partners. And those are the individuals who are living with drug-resistant TB. And we have some of them in the room. And I'm hoping that they'll tell you their feelings about slow rollout and observational research. So RRTB treatment prior to 2018 led to a significant amount of suffering. Right? We had to do it. It was the best we could do, but we should never underestimate the suffering that our older injectable containing and longer regimens cause to the men, women, and children who are all they did was breathe, right? The only reason people get drug-resistant TB is they breathe, which all of us in the room do. Low treatment success, permanent disability, right? To us in the TB world, we have an end of treatment outcome, right? Cured, you know, lost to follow-up, failed by treatment, because patients don't fail treatment, they're failed by treatment. But what happens to that person after we tick that box, okay? If they've lost their hearing, if they can't feel their feet and they can't engage in normal life, these are things that have caused them suffering, and we need to help them and be aware of this and try our best to prevent these things. So many of my colleagues have already showed you the WHO guidelines, and I'm certainly not an expert on them, but the WHO has taken great and innovative steps, okay, to recommend all oral shorter regimens for a majority of people living with drug-resistant TB. And in fact, Dr. Tedros, the head of the WHO, a year ago, said that by World TB Day 2020, no one should be started on an injectable agent for drug-resistant TB. So that's 20 days from now. Okay, and we have to ask ourselves, why are we clinging to these older regimens? What's in it for us? What's in it for patients? But the WHO has also said we can use operational research, which is a huge, huge, huge innovation for many of us. I think one of the concerns many of us have around the use of operational research in countries is that what we're seeing is that countries are replicating clinical trials protocols except within their own country. This is not what operational research is about. Operational research helps us figure out optimal strategies for the patients who come to us seeking help. Okay, so excluding children, wrong, okay, not okay, all right? Excluding pregnant women, also not okay. All right, excluding incarcerated individuals or people who are migrants and refugees, we can't do this in operational research. Okay, maybe in a clinical trial they have to do it, but we don't. And operational research needs to be about including people, not excluding people, okay? What we've seen is that in spite of very progressive WHO recommendations over the last 3 to 4 years, there's been limited uptake of innovation. We have this perverse notion, and people talk about this all the time, that we need to protect drugs, right? You say we need wider access to bedaquiline, and people say, but we need to protect those drugs. But that's not our job, actually. Our job is to protect the lives of people who come to us with drug-resistant TB, and we have to prioritize that. Okay, I mentioned already limited rollout of access to innovation because of complicated OR protocols. And the slide that you see here, the graph, this measures global uptake of new drugs, including bedaquiline and delamanid, against global need. Okay, and what we found is that fewer than 15% of people globally who need a new drug have had access to it over the last 3 years. This isn't okay, right? We need to urgently increase access to these things. We need to do it in a careful way where we monitor how people are doing, but that's just good MDR-TB care, okay? When we look at systems for operational research, that helps us improve our monitoring and evaluation. Operational research needs to be integrated into what we're doing, not as a standalone. And I think looking around this room, there are people sitting here who have excellent experience doing this. You know, I was struck by Dr. Skorhina's presentation in Belarus. You know, Belarus was the first country in this region to give bedaquiline to adolescents. Okay, and that's because even though Dr. Skorhina, who I've had the great pleasure of working with for many years, she says the WHO guidelines are her Bible, and in many ways she's right, because they give her a framework for what she does in Belarus, because she adapts it to the needs of her population. And I think that's how all of us have to start thinking, right? The WHO gives us a framework, but our job is to adapt it to the needs of people in our countries and the places where we work. So I think there's a lot of expertise in the room, and I hope this afternoon that we'll be able to share ideas with each other about how to more rapidly innovate these badly needed interventions instead of sticking to a very old regimen that causes suffering and has never been proven in clinical trials to be effective. So the last thing I wanted to focus on is this idea of person-centered care. So we talk about it all the time, right? It's a pillar in the WHO strategy, but often our language around this is cosmetic. Okay, what do we mean by person-centered care? It's not just about adherence support. This was a study that was done in South Africa by several of my colleagues and I, where we looked at where people need person-centered support. And there are 4 periods where people need support. It's the time when they have symptoms before they have a diagnosis. It's the time when they have a diagnosis, but before they start treatment. Okay, it's the time when they're on treatment, and then it's the time after treatment. Okay, and while there are unique needs in these areas, there are cross-cutting issues as well, largely socioeconomic needs. Okay, for most of the people in our communities living with drug-resistant TB, TB is not their only problem. And we had a very frank discussion with some of my colleagues from Afghanistan yesterday as we were going to visit the lovely Zhytomyr project. How do we address this? What do we do for a family where the children don't have clothes? Okay, this is a pressing need for people living with drug-resistant TB when they don't have food, clothes. How do we help them address these issues? And most of the time we don't, because we don't know how to solve them. And I think our colleagues from Zhytomyr have come up with some excellent ways of addressing these things using partnerships. Right? We don't have to do it all ourselves. So in conclusion, we need to be urgently implementing all oral short course regimens for a majority of people who are living with drug-resistant TB. Settling back on the older way of doing things is not appropriate. Okay, if you're giving injectables to your patients routinely, you're essentially poisoning them. And we have to stop that, and we have to stop it now. We need to embrace a human rights focus for the treatment of people who are living with drug-resistant TB, and we have to keep preparing ourselves for innovation. It's wonderful the WHO issues new guidelines every year. This means we have science and we're progressing, and we need to embrace this. It's our duty as people who've dedicated their lives to the service of people who are living with drug-resistant TB. So thank you for the time and allowing me to speak.
Thank you very much, Jennifer. Thank you very much for this great presentation, and as always, you are the voice of people with TB, and I'm really grateful that you raised this important point about the terminology, especially when we are talking about the real people who are around us today. So thank you very much. And as you mentioned, WHO were strongly recommended the transition to oral regime by this World TB Day, but I think it will be postponed to the next World TB Day, and all of us, we need to think why it happened, and maybe we need to think how we need to join our efforts to make it happen by the next World TB Day. So thank you very much, and I want to present the next speaker, who will be the last speaker for the session today. It's Oля Klimenko. Oля became a passionate TB activist after her illness in 2015. She's an author of a book, My Inner World, Confession of TB Patients, and since 2018, she became a strong activist mobilizing the community and protecting the right of people all around Ukraine. And Oля is the head of TB People of Ukraine, and she's the member of the board member of TB Europe Coalition, and she is the head of a national network of people affected by TB. So Oля will now speak about the right of people with TB and the tools for monitoring. And right after this presentation, we will have a panel discussion. So please prepare your question to panelists. Oля.
Thank you, Yulia. Thank you, Jennifer. Friends, I will speak on Russia. Please take your headphones. Добрый день, друзья.
Good afternoon, dear friends. I am happy to be here, to see many familiar faces, to meet new people. Like Yulia said, my name is Oleg Klimenko. I'm a head of the board of network of people with TB, those who were cured or those who are still on treatment. And using your terminology, I'm a successful case of cured TB. And actually, this is what we are standing for. Actually, I couldn't but mention that. Many people stress on that. I think that's important. It's impossible to fight for lives unless you represent life with people, associate life with people. We should remember always what we're standing for. I will be speaking not about medical part of TB, not medical side, but about changes related to our expectations, which are not really met after the General Assembly, which took place in 2018, when the countries assumed committed themselves to conquer TB and put most of the efforts. But the practice shows that since 2018, only ministries of health in every country keep fighting TB. I'm speaking only about Ukraine, and I don't know how about other countries. And our organization has also representations in other countries like Africa, African countries, in Indonesia. So we know the situation globally. And to speak about some achievements, when you understand that TB is still regarded as a medical condition, probably it would be not quite right. That is why when we try to influence the policies, and TB People Ukraine is an advocacy organization. We don't provide services. We operate at the national and local levels to change policies, to develop programs, to protect patients' rights. And what we saw, that apart from dealing with the medical side, we can't do anything else. We should admit that, because everything related to social or legal, psychological issues is not included into the national budgets, is not included into the programs. That is why when healthcare workers take the responsibility of a person who maybe wants to be treated, but some circumstances don't allow him or her to be treated, in this case, a doctor becomes a hostage of the patient's social problems. That is why this under-communication can be one of the reasons, because a healthcare worker cannot solve another person's problems. All the barriers should be discussed at the national level, at the round table, at the top level. But when we try to highlight these issues, One Impact, the mobile app, One Stop TB partnership initiated creation of this app. This was due to absence of centralized data collection in the world. Every country doesn't have a system which could collect patients' needs information to have evidence when we are fighting for people's interests. That is why this mobile app is an assistant for patients, for healthcare workers, for everyone who deals with TB, in order to communicate the problem. For us, it's important to have this database. The capacities of this mobile app will be presented later. First, this slide is about declaration. And declaration and the mobile app are interconnected tools. The declaration was developed under support of Stop TB Partnership and the Global Fund. When we started adapting that, we faced a completely different challenge and problem. The patients don't know their rights. You can't introduce mobile app which they would use to inform about their barriers if a person doesn't understand that his or her human rights are violated. And this brings us back to standards of consultations. What information does a patient get when he is diagnosed TB positive? This depends on various things like political situation in the country, in the city, doctor's mood, patient's mood as well. And there is no universal approach what a patient should hear about his current condition. That is why in order to come up in a systematic way to patients' education. The Patients' Charter in 2019 was created. It includes the key rights that every person should have, not only with TB, because similar issues arise among people living with HIV and other people, other key populations. The declaration itself is a charter which is not applicable in our countries. It was created, it was developed, but to make it effective tool to make changes in your country, this declaration should go through certain changes. Since in every country the situation is different in terms of approaches and conditions and regulatory framework and political situation in the country as well as funding, that is why to make the declaration an effective assistant in advocacy in your country, it should go through adaptation period, like a mobile app in every country as well. Currently, TB People Ukraine, under support of the partners at the national level, Center for Public Health, our declaration is translated into Ukrainian and it was verified by lawyers. So currently we know about discrepancies with the regulatory framework. And this is needed to develop the collective advocacy approach, which could unite all the partners for them to speak the same language, to have the same messages, and to make changes to policies. The mobile app, when you have a tool and when you know your rights, then it's easier to use this mobile app, which provides access to information, counseling, psychological and legal support, coding, all medical facilities and NGOs in the area where you are right now, because this is a geolocation-based app. And this is a good thing in conditions of decentralization of health facilities, for a person to understand where he or she can get help. And here we faced another barrier, and I always keep mentioning it. You know, it's good when there is a project which supports good initiatives. What happens to all good initiatives after project completion? Actually nothing. Most of the initiatives die out or become inefficient. If we look at the map, 24 oblasts of Ukraine plus Crimea, which is not covered, we have 172 appeals from 7 regions, which doesn't mean that in the rest of the regions there are no people with violated rights. It means we have no chance to influence that in those regions, and it means that the projects are not effective in those regions.
And they have only 1 minute left, but still I will try to make. If you look at the yellow bit here, well, when they say that patients often need financial support, but we have only 2 calls like that. So these 20% of others, this was related to non-medical aspects, social assistance with children, psychological support, legal counsel, getting fired from their job, finding help with educating their children for teenagers. So here, well, it says 20%, although actually it's 44, it should be 44, because yesterday we reconciled the figures. This is my child, who really was lucky. She has not become a case, but she went through the path of being a contact child, and she underwent all the difficulties, and she endured what her mother was enduring. And she knows what children's sanatorium school is, and I know how it is when there are no conditions for children. And my recommendation is, and I keep saying that for the last year, one can't change approaches, one can't overcome TB if we have our own individual interests or individual policies. The world has no consolidated approach on countering TB, and unfortunately, as of today, merely joining efforts is not enough, because very often we see that it's only medical organizations that join the efforts, but we have to engage all the stakeholders really in order to overcome TB, and only when all the ministries, all the different ministries will admit that they also have to control TB, then we will overcome this, because this is the responsibility of each of us.
Thank you very much for the presentation. And I want to add thank you for raising a topic that often is neglected, especially in this kind of events, which is human rights. And you are proposing also, you're sharing a possible solution. The app seems amazing. Yesterday I took a look and also saw that there is the possibility for the patient to say if there is drug stock out. I think that's fantastic, and maybe also the HIV world will steal the idea. Anyway, so I think it's a good way to introduce the plenary discussion. And maybe I can start just by stealing a sentence that Dr. Jennifer, she said. Dear TB patients, the only problem, their only fault was to breathe dear TB strains. And again, what a change where we are now. We remember, I'm sure we all remember, when we were pointing fingers at patients saying, this is your fault. Now we know it's not their fault. We know there is primary transmission. We know that the solution is not to control, to hospitalize, to mandatory hospitalize, but we need to find other solutions that are much more patient care, that include psychosocial support, that include education, innovative tools. And I think we can open for questions. Yes, should we start with open questions? Please raise your hand.
Yeah, so we pleased to announce our panel discussion with our amazing speakers. And when you will ask your question, please mention your name and the organization and to whom you address your question. So do we have any questions? We have two questions, 3, yes. Can we pass the mic to Yulia from the, yeah.
This is a very exciting panel. Thank you so much, dear presenters, for bringing such acute questions, which helps us think differently. I really appreciate. My takeaway from here, and as for the decision, that we should take an approach which could be support, do not control. The way the people who are working in drug addictions, one took support, do not punish. And my question is to MSF colleagues, to the Tomer projects, to work in Uzbekistan. What are the perspectives for sustainability of your efforts? Because you do a really great job with a very good outcome. How the healthcare system is prepared to take on these developments and to continue in this way? What is this bridge? Thank you.
So the thing is, Uzbekistan already supports about 1,600 patients. We are almost completely embedded in the Ministry of Health, and we work with them. So a lot of our role is not so much about actually monitoring hands-on, but to help support them technically in something which they're already pretty good at, because some of them have been working on it for a longer time than I have.
So, I mean, I think that in the long run, as long as we are here to support them, it's good, but I'm sure they'll do a fantastic job even after we're gone.
In Zhytomyr, we believe in knowledge transfer. So we currently are piloting a mentorship program to enable continuous updating of knowledge for the health workers that we work with in ambulatory care. So that will cover the clinical care, but additionally the psychosocial care that the patients need. And then also we started working with the village leaders. So in one district where we work in Brasilia, for example, we have engaged the Romadas. And there, I think some of the participants visited yesterday, and they saw for themselves how the local community is actually working to support the the patients with TB in their community. So that actually is a very strong point for the region to sustain, to make psychosocial support sustainable for the patients.
Thank you very much for the question and answer. Yes.
Dear colleagues, I have been working in TB care for 40 years. I have started my work back then when inpatient care lasted probably about 6 or 7 months. Under daily supervision, the patients took treatment. Of course, we had matters with breach of treatment scheme, but anyway, we had less DRTB. Now, having heard the colleague Janata Naga, we see that there's a problem with lack of evidence for DOT. So what comes next then? Now, this section is extremely important, I think. It is extremely important because we have to consider not only the rights of patients, because we seem to forget about the responsibility of patients. This is a matter which we omit. In Ukraine, we do not know when can we allow a patient who, for example, has the MDR for the first time. We don't know when can they be allowed back to work. Can they teach at schools? Can they teach for junior children? Can they work as a medical doctor, as a surgeon? We don't know this. So we have heard these fantastic presentations. Could you please share your experience on this? Thank you.
Switch to Russian. Спасибо большое за вопрос. Он действительно очень важный.
Thank you so much. Indeed, it is a very, very important question. I hope the speakers will be very helpful. Olga and then Jennifer.
Я не буду говорить.
I will not mention the medical component because there are qualified doctors who can respond. But as for our vision and our opinion on this, when we talk about patients' rights, we presume responsibility. We never merely protect only one side. Our goal is to create a system where everybody does their part, does their duty. If we look at the declaration, we have included patient responsibility there. Because, well, you can't only create the conditions for patients. It would not be fair. It wouldn't be fair to everyone. As for DOT, not all the needs of patients have been studied when the DOT model was created. And I'm not mentioning this in the context of the medical efficacy, but also there are questions of patient's life and social activities, because the whole model of outpatient care, I was an outpatient patient, is to bring the person back home to their social life. You can't just send the person back home and tell that you have to be every day at 8 o'clock in the morning in the hospital. The person will not have normal work, so they anyway will be a kind of a burden for their family and for the state. So we don't say that DOT is bad as such. We mean that in order for DOT to be really good, we need to consider the needs of the patients wider. So maybe we need an additional study for DOT. I would like to add to what Olga said. When we talk about the patient-oriented approach, when we say that patients must be able to receive counseling so that they would understand their rights. And with this we also explain that they carry responsibility for their life and their health. So, if we counsel properly, if we tell patients about treatment, what's going on, what will be coming, and this process, already the doctor is kind of putting some responsibility onto the patient, because now the patient knows what do they have to take and what is their responsibility. Jennifer?
Yes, so thank you, Doctor, for your question and your comment. I just have a few medical things that you raised that I'm hoping to address. You know, 40 years ago, we weren't routinely using rifampin, and we didn't do a lot of drug susceptibility testing, so I think it's hard to compare those situations to the current situation. The system of DOT was invented quite a long time ago, and it was somewhat punitive. You know, TB is a disease that's based on a fundamental mistrust between providers and people who are coming to those providers asking for help. And you know, when the first thing is, I don't even trust you enough to take your medicine, we have a problem there. And it may be one of the reasons why, in spite of being curable, tuberculosis is the leading infectious killer of adults worldwide. There have been numerous studies that have shown actually that DOT may be harmful. For example, a study done by a colleague of mine looking at patients who were living with drug-resistant TB and HIV found that people were very adherent to their antiretroviral therapy, but not so adherent to their drug-resistant TB therapy. And some of this was due to pill burden and side effects, but a lot of it was due to the fact that the patients felt responsible for their HIV treatment, whereas the system of DOT felt very infantilizing to them, and they said, well, that's, you know, those people don't even trust me, so why am I going to worry about my medication? So I think we have to understand that this old system that was developed almost 50 years ago, it's probably not appropriate in this age. I'm glad you brought up the issue of patient responsibility. I have to say, people living with TB are some of the most responsible people I've ever met. Think about feeling sick and having many other problems and going every single day to the clinic. I mean, that's a high degree of responsibility. But sometimes we use these terms, your rights and your responsibilities, in a transactional way, as if you give me money and I'll give you a loaf of bread, right? When really the better way to view rights and responsibilities is as a partnership, right? And I'm getting to your last question, which is where do we go from here? So when we engage with people who are ultimately responsible for taking their medications, when we engage in that with them in a sense of partnership, right, where we do things and they do things and we talk to each other about those things and where we're struggling and they're struggling, that is the answer to how we move forward. Right? We have to get rid of these old fear-based practices. And the last comment I wanted to make, even around infection control, we use fear-based practices, right? The question, can they teach in schools? Can they, you know, people who are on treatment for their TB, if they're on correct treatment, become non-infectious within 48 hours. So these old practices of deeming people, you know, a risk to others or a risk to themselves, those also have to go away. We have to move from fear-based to partnership-based and do it in a genuine way. Sorry for long.
Can I add something? And Doctor, this is really the kind of, I think, debate we need to have, because probably you're not the only one also thinking and remembering how things were done before, and maybe they did work. Now I think we have evidence, and again, I think no one here is saying that DOT is an absolute no. I think what we are saying is that we need to adapt the strategy, putting the patient in the center. So for some patients, DOT, community DOT or other forms might be the best solution, and for others may not. I'm thinking a little bit that this might be a similarity with the discussion on the injectable that we were having earlier, and also this need, this absolute need that we have to switch to oral regimens as soon as possible. A question I didn't have time to ask before, it was, is there any, I know that in the region, we used to love the injectable. Sometimes also patients say it's always been considered a strong drug. And now we have clear evidence that this is not only the case, but that we have much, much better options. So how can we make sure that the evidence we have, and also this evidence that has been discussed about DOT, the evidence around ambulatory care that led to WHO recommendations, how can we make sure that this evidence brings to fast implementation, overcoming some barriers that might be due to our own practice? We all have our own way of dealing sometimes with patients, but there is evidence and we need to use it, and we need to move quickly to better regimens which help adherence, probably much better than DOT. Sorry, that was long. Should we take some other questions? Or?
There was a question from that side? No? Yeah.
Thank you.
Okay.
I have a question to Olga.
I'm sorry, can you point your name and organization?
I'm Dr. Pranita Tipre. I'm from Mumbai, India. I'm working as a city TB officer in Mumbai. I have this question to you because when you said the app which was created for the rights of the patients, I just want to understand from you what was the reaction from all healthcare providers, whether they accepted this app or there was a negative reaction. As the statement done, the fear-based to partnership-based, we can very well use this app as a partnership model, So that's what, just out of curiosity, I'm asking whether the healthcare provided it gracefully or there were negative reactions, because I'm sure the patients, they're right and they want the answers and the drugs in time. Thank you.
Thank you for the question, Ola.
Спасибо за вопрос.
Thank you for the question. This is a very important period we've gone through in terms of introducing mobile app. TB people Ukraine, we are kind of unique in our approaches because our organization is trying to do everything in a centralized way, together with the Center for Public Health, with the ministry. We never implement our activities just as a society, as an organization. If we set the goal to change the system, not just to implement an activity, then the system should participate in the process. That is why at the national level it was easier. At the local level, I want to say that in general, mobile app in TB is something which is not taken easily, because HIV subject, which has already 3 electronic tools, it's more advanced. The users are more advanced, and it's more discussed. When we started mobile app for TB, many people didn't perceive it easily because TB is still a tabooed subject. We're trying to fight the epidemic, but we're doing this very quietly. And some people are still ashamed of that. There were issues of confidentiality, and healthcare workers, depending on the regions, quite often had aggressive reaction, because what patient says probably will be never liked by a doctor, because every day a doctor puts a lot of efforts in treatment, in doing his job, but he or she is doing that, in his or her opinion, in a good or maybe not so good way. And when a patient says that he doesn't like something, in any case, this will cause some negative reaction. That is why we admit that sometimes doctors are against patients who tell about their barriers or problems, and we're trying to find other ways of communication. The purpose of this mobile app is not to complain about medical workers, because we all admit that there are changes in place, no matter whether we want it or not. There are changes and they will continue. In some places faster, in some places slower. And healthcare workers also require a special approach, just like patients. Maybe someday we will have a medical-centered approach. And when they see these tools, these mechanisms, we have 1,100 users. Of them, about 40% are healthcare workers. Because to admit the fact that you need help in terms of information is very important, and this was one of our biggest victories when healthcare workers, not only doctors but also nurses, social workers, when they started applying to us, not to us but to mobile app, because this shows their readiness and willingness to overcome the barriers, which is very important. This is a difficult process, but we have more progress today. The more you speak about some solved issues, the better people see how this tool works.
Take only one more short, very short question and short answer. Thank you very much.
Olena Skryagina, Belarus.
Olena Skryagina, Belarus, NTP. I have the question to Jennifer. That's why I'll switch to English.
For your excellent presentation, and I very like your idea. We should be prepared for additional innovation in the nearest futures. Can you give us more detailed answer? What should country do to be prepared?
Great, thanks, Elena. But it's a great question. So, you know, TB is an evolving field, and it's exciting. HIV deals with innovation and implementation all the time. And I think in TB, we tend to have a tendency to stick with tradition, right? And, well, we've always done it this way. Our tradition is very important. But now we have the beautiful opportunity to learn how to change quickly. So we need a faster process for updating not only WHO guidelines, but country guidelines. We have these old processes where a bunch of people come together for 2 weeks and they meet and then they issue and then they print and then a new innovation comes and they say, we can't update our guidelines because we just printed our guidelines. You know, and I think, so we have to be ready to change our guidelines quickly. We need our donors and our partners to be responsive, to quickly change things, help things get imported. The drug procurement system for drug-resistant TB, where we order maybe once every 2 years, we have to stop that. We have to forecast more quickly. We have to order more quickly. And I think we always should check in with people who are living with drug-resistant TB, right? So how do these updates affect you? What do you think about them? How would you like us to take care of these things? And things will move much more quickly under those circumstances. And I'm sure you probably have answers to, Elena. You've adapted things very quickly in Belarus. So thank you.
And we are coming to the end of our panel discussion, and thank you very much for such a productive, interactive, and emotional discussion. Thank you very much. And we will have a coffee break after this panel discussion, and we would kindly ask everyone to come in half an hour at 4 p.m. And my colleague will conclude this panel discussion and what we discussed. Okay.
Sure that the long journey of treatment to cure is successful, we need to bring as soon as possible and find and use safer and better regimens, starting from something that can happen as of tomorrow, which is oral regimens. That's all. Thanks to all.
Thank you. It's not switching off.
We have reached our last presentation session of the day. If you haven't tweeted yet, please do so using the hashtag TB Symposium. The next hour will delve into the issue of stigma. We all know that it's a huge barrier and it can present a big burden, mental health burden for the patients. But what can we do about it? This would be the topic of discussion. And this session will be chaired by MSF Medical Coordinator Khachatur Malakyan and Jennifer Furin, infectious diseases physician and medical anthropologist who lectures at Harvard Medical School in the Department of Global Health and Social Medicine.
Thank you, Alex. I'm glad to introduce the first speaker today, Alona Trash. She's working with us in Zhytomyr project, and she's a great support to both teams, patients, partners, colleagues, communities. Please, Alona, the floor is yours.
Уважаемые гости, уважаемые коллеги,
Dear guests, dear colleagues, with your permission, I will speak in Ukrainian because it will be easier for me to speak about stigma in Ukrainian.
я працюю медичним координатором в проєкті.
With your permission, I will speak Ukrainian. I have been working in the MSF project in Zhytomyr, and great support is provided to our patients at the outpatient treatment period. This is the period when patients require a lot of different types of support. And what we observed is that these are usually the PHC providers that have a lot of stigmatizing practices, unwillingness to provide such care and support to our patients. So we decided to organize training for PHC physicians and nurses to reduce their stigma approaches to TB patients. So the purpose of the training was to help the participants of the training to find and realize their own fears and their stigma to TB patients. We wanted to provide them, the participants, with the proper information that could enable them to bust the myths in that field, and also to breed a new understanding of the values and the proper understanding of the needs of TB patients. We do understand that stigma is not an easy issue, and only by means of providing proper information is definitely not enough, because stigma is about fear. This is about your inner fearful sensations that have been developed inside. Sometimes it is very much innate fear, and you cannot break it down by means of telling what the TB is only. Therefore, we engaged a psychologist and a TB experts to the training as teaching staff, and we think this combination of teaching staff was really very adequate and very proper approach. That was a 2-day 6-session training. Each session had information component where information, factual information would be provided, and also it included a very big psychological component that enabled the healthcare professionals really to go deeper and talk deeper about their views, perceptions, and opinions of every participant, thus reducing the level of stigma that would lead to depersonification of the patient and would lead to proclivity to stigma, towards stigma. Healthcare professionals would include doctors, nurses, and felchers, and the regional Oblast Regional TB Center really helped a lot in doing that. That was not an easy task, definitely, to organize it. We collected the complete list of all the participants that could be involved from the PhD level. We prepared a sampling size of participants who could participate. We had basically 24 trainings organized for each of the district, and we invited 20 to 24 persons from every district, and we basically covered 458 participants. Two-thirds of that were the primary healthcare nurses as well as healthcare professionals at the rural health posts. These are the PHC workers who are usually ignored during some information or training practices plans. These were usually people who would be working out there in the field for 20 or 30 years without any specific training at all. But we really wanted to have these people who would cooperate with the patients on a daily basis, routine basis, ensuring DOT treatment for those patients who could really serve as eyes and ears to our system. For that purpose, we had to teach them, we had to train them and provide them with proper information. So, usually we would have a TB expert and a psychologist acting as trainers to the training. That was a very successful combination, I would say. It enabled the participants really to talk about their fears, about their opinions and their position. We have had some very fervent discussions and debates. Sometimes the storm really had to be brought down by the psychologist, and people really had to be provided with proper, adequate information, and we had to make sure that really people memorize this information properly. Therefore, that combination of TB expert and the psychologist was really the best possible choice. We planned to have a pre-training and post-training questionnaire. Speaking of pre-training, we selected 40 standardized questions to evaluate the stigma level among healthcare professionals. And just for your information, I provided here on the slide a couple of questions and answers demonstrating their current level of knowledge. Up to 60% of healthcare workers thought that using disinfectants for their hands treatment would protect you from TB. 75% of healthcare workers think that TB can be caused as a result of violation of your personal hygiene and unhealthy way of life. Pay attention, these are the healthcare professionals, though they cover not only TB issues, they cover a whole wide range of other public health issues. Up to 90% people thought that TB is actually not the fault of the patient, but progression of the disease because of intake of alcohol, for example, and not taking pills is actually the fault of a patient. This is what they thought. Therefore, we had to really very much focus on alcohol and TB drugs issue. A lot of people thought, up to 53% thought that their family and people around them thought that they were not happy with the fact that healthcare professional had to work with the TB patients. And only 40% thought that was not the case. That was the baseline figures. And as I mentioned, our training was organized in 2 days sessions. I will briefly update you on what sessions were. We briefly talked about stigma, what is stigma, how it affects the daily routine of healthcare professionals. We had an extended session devoted to myths with TB. We also talked about infections control. They would have to draw the path of the patient from the very first presentation to the doctor, then diagnostics, treatment, coming back for outpatient treatment, further treatment and follow-up. And we discussed at what point the patient could be dangerous to the healthcare professional, and they got suddenly realized that they were also in the risk group, starting from the very beginning of that process. We also had a very extensive session devoted to how you should deal with patients taking alcohol, abusing with alcohol. Many people said, like, how can I talk to a person like that? How can a person realize anything if he or she consumes alcohol? They basically didn't have any communication skills talking to them because they were very much afraid of those comorbidities or some other conditions that might be associated with TB and patients like that. We also had some representatives from TB People Ukraine NGO. They really it really enabled us really to teach the healthcare professionals how to organize dialogue with a person like that. That was very important from the emotional point of view because it really developed the empathy between healthcare professionals and the patients. It really made it much clearer for the healthcare professionals how to organize the whole pathway. And we also focused on the issue of professional burnout because people are very much overloaded with all different types of problems with healthcare reform going on, and they also have to deal with some other issues like TB and some other problems. To conclude with, let me give you a couple of statements from two participants, because usually every training would be concluded by asking the participants what you thought about, what were your opinions in the beginning, and as far as we had a very open discussion, these are very genuine, very sincere thoughts. Yesterday, we had some fears and myths busted. We did realize that we were mistaken at some points. Some efforts need to be made, and I must tell you, the training made me think about some other approaches, how we can improve our cooperation from the side of nurses and healthcare professionals, because many of us thought, like, why would I be dealing, what would I be managing the patient? I have children at home, I have family at home, there is a social service, why don't they deal with those patients? But now, when we get specialized knowledge on that, now we finally realize these are just common people, and we can provide them with proper care without any risk for our health and our future. I do not know how my colleagues think, but I must tell you, I need time, more time, really to get reconciliated with what you talked about. Because you remember what happened in the old TB dispensaries? Well, the remnants of food from TB patients would be collected into some bins and then would be treated with chlorine. This is what we got used to. This is something that we very much got used to, and now, even with the availability of this new information, I can't believe that very quickly. And let me tell you that the post-training questionnaire was performed in a 3 months period after that. Just recently we have collected the most recent data, and the preliminary analysis shows that the level of knowledge regarding the transmission ways improved, the level of self-stigma reduced by 30%. Stigma regarding alcohol and TB drugs has not changed a lot, but we still think this is a very good approach when you combine information sharing, awareness raising, and psychological support. That needs to be done that way, and it is definitely very important really to provide healthcare professionals at the PhD level about alcohol abuse, about comorbidities in TB patients, because healthcare workers are not aware of that. They are afraid not only of TB, but everything else associated and surrounding TB, and that is a great barrier to managing such patients. Thank you very much.
A beautiful presentation. I think Zhytomyr, along with the Department of Health and MSF, is doing some really innovative work around drug-resistant TB. But I think, as you all are showing in the project, we can't just focus on new drugs and shorter regimens. There are many other aspects of TB and drug-resistant TB that we need to pay attention to. And it's great to see the work that you're doing, so congratulations. So it gives me great pleasure to invite to the stage our next speaker, Dr. Veena Karir. Dr. Karir actually is a pharmacist by training, but as all good pharmacists do, she does not stand behind a counter doling out medication. She's actually currently the Regional Advocacy Manager for Uzbekistan and Tajikistan for MSF. She has a long experience with MSF, in fact, in multiple settings and in multiple roles. She has her master's in epidemiology from the University of Washington, and she's done postdoctoral training in health services research at the University of Pittsburgh and the RAND Corporation. So she's going to talk to us today about another approach to engage with the community around TB stigma, the Telegram channel. So thank you so much, Dr. Karir.
Thank you, Jennifer, for the introduction, and good afternoon to everyone. As many of you have already aware, there are many challenges to providing care for TB. There's a lot of myths surrounding transmission of the disease, diagnosis, as well as treatment. There's also a basic lack of understanding about the disease. It's particularly a problem in areas where there's a high prevalence of tuberculosis, and in particular in a region where there's also a high prevalence of multi-drug resistant tuberculosis. As many of you have also already pointed out, stigma is a challenge. In Karakalpakstan, where MSF has a project in collaboration with the Ministry of Health, the area is just a vast it's a vast region relative to the population size, and it's around roughly 3 times the size of the Netherlands, and so the reach is also great. We are already engaging with the community. There's mass media happening. It's mostly through radio, some television. There are workshops. Last year, at the end of the year, there was a workshop about survivors of tuberculosis. There are public events, but those tend to be more punctual. So examples are like World Tuberculosis Day, awareness of antibiotics. It was Antibiotic Awareness Week. But it's still not enough. So in 2019, we started to look towards social media. The Telegram app is widely used in the region, particularly in Karakalpakstan. Although we wouldn't be reaching out to everybody, we decided to at least target people who could have access to social media. So it was largely a population range between 15 and probably 50. It would be in the regional language of Karakalpak, but people who spoke Kazakh and Uzbek would also be able to understand. One of the, I think, important parts of this app was that it would offer some privacy. As many of you are aware, people might be embarrassed or afraid to ask the questions that they really wanted to understand about tuberculosis. So this application was probably a mechanism for people to be able to do so. And resource-wise, at the time, it didn't seem like it would be so resource-intensive. So we would need some human resources to manage the sites, and basically a stable mobile data package that people could actually have more of an interactive mechanism to ask questions. So how does it work? There are 3 components to the Telegram channel. There's the actual channel, which is TB is curable. There's the interactive bot, which is essentially a software account. and that's at TB Mythspot. This is actually where there's information about the disease, there's information on myths, and also there's other concepts included that are taken from focus group discussions. And then third component is an anonymous interactive also bot that's where individuals can ask questions and have answers from either Ministry of Health physicians or MSF physicians. These are confidential, and because many of you are probably aware it might be the same questions that others have, the questions are then paraphrased and then posted on one of the weekly one of the weekly posts. So people can access it by downloading the Telegram app. You can search for the TB channel, which is at TB is Curable, and press the join button. You can then subscribe to the channel, which then gives you access to view the information. If they decide to activate the bot, then you can actually submit questions to physicians. And then if you decide to activate the myth bot, then you can actually have access to the interactive menu where you can actually access questions that other people might have asked and information on the disease. Just to give you an example of some, or sample rather, some of the questions that come across. One of them was, do TB health professionals or providers take medications to prevent becoming sick with TB? How many types of TB exist? And then another individual asked, I fell sick with TB 1.5 years ago. Yesterday evening I had a bad fever. Can it be because of the ulcer in my lungs? In terms of response, we officially launched the Telegram app in 2019 during World TB Day. The initial subscribership was around 130 people, and then as the beginning of February, it's around 327, and then most recently it's increased to around 380 subscribers. Individual posts average about 590 views, and then the weekly posts, which can also be shared on other Telegram channels, can generate up to 10,000 views. So some of the lessons learned. Getting new subscribers is challenging. It takes time. We don't have as many subscribers as we probably had hoped for. More views also takes active promotion, so the site has to be routinely monitored to remove spam, but also to make sure that the content is adequate and effective. And then investing in custom designed posts probably has some advantages, so basically more graphics and more sort of aesthetics that catch people's eyes probably can also increase views. So in summary, the Telegram channel, TB is Curable, is an innovative real-time exchange platform to increase awareness, but mostly I think it's a way, it's a mechanism for people to engage without fear or embarrassment. It's available anytime if you have the Telegram channel and have a secure access to internet. It can also be adopted to other priorities and contexts, and minimal resources are needed. This initiative wouldn't be possible if we didn't have the support of the Ministry of Health from Karakalpakstan, as well as the doctors from MOH and MSF, and of course the project team of NUCAS. Thank you for your attention.
Thank you, Dr. Vina, for this excellent presentation and sharing the experience that you have in Karakalpakstan in Uzbekistan. This is an example of how the geographical, let's say, dimensions can affect the stigma. What is the cause of stigma? As you already have presented, both of you, it is myths and lack of knowledge, mostly because of fear of getting infected. So raising the awareness, improving the knowledge is another tool, another way to improve, to destigmatize the tuberculosis, as well as it may be related to, associated to other diseases like HIV co-infected or low social economic conditions. That's why all these myths, it's important and necessary to kind of destroy these myths, increase the knowledge about tuberculosis, about curable, etc., etc. Thank you. I have opportunity to introduce another colleague of mine, Olga Zaitseva. I can introduce her for long. She's a doctor, pediatrician by specialization, worked as a clinician after graduation of medical institute. Then she was a TB coordinator, and nowadays she's working in a public health center in Kiev. She's supporting the project in Zhytomyr. I am working with Dr. Olga probably on daily basis. She's overviewing clinical aspects in Zhytomyr project. Thank you, Dr. Olga. The floor is yours.
Добрый день, уважаемые коллеги. Спасибо за то, что находитесь.
Hello, dear colleagues. Thank you for finding time to keep your attention up. We understand that this is afternoon, this is another panel discussions, but still, the matters of outpatient care for TB patients, they are so important that they do require your attention. And in my presentation, I would like to present you the current situation of outpatient care for TB in Ukraine and our subsequent steps in this direction. Up until very recently, the organization of TB care for the people of Ukraine was mostly based on the principle of isolation in inpatient conditions. And to some extent, this was conditioned by a certain verticalization. We had silos of TB service. It was not integrated enough into the general healthcare system. The Cabinet of Ministers of Ukraine has approved the strategy to develop the TB care in Ukraine. It was adopted in November 2019, and it sets quite an ambitious goal. By 2023, to create a more flexible model of providing higher quality and TB care and treatment services with higher availability. In order to achieve that, we see the following main directions where we're going to move in the next 3 years. First of all, we'll improve policies and bylaws on outpatient care, including on how to engage primary care providers. Number 2 is improving the availability of care at, well, once again, at primary level, and increasing patients' trust and confidence in this model. Because the outpatient care engaging primary care will help us also reach the key populations and vulnerable group. Also, we will engage interactive methods of primary care observed treatment. We will make sure people have the possibility to get outpatient treatment from the first day of diagnosis. One of the key methods is the implementation of the so-called medical guarantees program, where the state budget pays for the package of services at the outpatient level. As a result of all this, by 2023, we have set the following indicators. We want to increase the share of patients that start outpatient treatment from day one to 65%. We see that the baseline is somewhat different, really. And we want to shorten the length of inpatient stay for both patients with sensitive and resistant TB. The reorganization of TB program presumes the redistribution of roles and responsibilities and more effective cooperation of all the levels of care. So you see that all the pyramid here is essentially based at quite a large scope of events that have to be done at primary level. The prevention, early detection, diagnostics, and subsequent treatment. I just want to note that the governmental policy for TB control in Ukraine is based on the principle of reasonability. I mean, we use evidence-based approach in decision-making. So besides the evidence that is collected by the WHO, Ukraine also is developing internal operational research. As Jana already has said, the Public Health Center has a research coordination department. We have the ethical committee, and they run the processes of assessment of social and behavioral studies. So I want to know that in 2019 we have conducted an operational research on primary care provider preparedness for HIV prevention and treatment services, for TB, HIV, and other socially significant diseases. It included actually HIV, TB, and viral hepatitis, and also opioid substitution therapy and palliative patients at the outpatient stage. So quite a comprehensive study. 800 respondents involved. They were GPs and pediatricians. And we used the interview method, face-to-face interview, directly at the workplaces. The study involved several blocks, and one of the first blocks was the perception. How do the doctors perceive the possibilities of working with different patients, including patients from key populations? I want to know that patients with TB, only 6% of the respondents have noted that this group is the most difficult, quote-unquote, to work with. The leading group, the 32% of the providers said that the most difficult group to work is with people who have alcohol addiction. Number two was people with drug addiction, and number three, 22% of providers said that it's difficult to work with elderly people. Also, we are interested in the doctor's preparedness to provide services to these key populations. And that is why, to start this, we have developed a scale of 5, where every grade, so the higher the grade, the level was the level of preparedness. So 1 means the doctors are ready and open and prepared, and number 5 means they are basically isolating themselves. And then for each population, we have calculated the average index of the doctor's reluctance to work. And as you can see, for key populations, our providers are quite open, like 80 to 90% of the respondents have said that they are ready to work with them. 76% of the surveyed doctors say that they are ready to deal with referrals of these patients when necessary. They can refer to social services, rehabilitation services, and they are ready to cooperate with NGOs. Well, that was regarding key populations, the risk groups. When we talk about TB patients as such, here the picture changes drastically in certain aspects. When we calculated this reluctance index, You see, we have patients with viral hepatitis C, B, with TB, shedding, non-shedding, and HIV positive patients. We see that the highest reluctance index, that when the doctors want to basically have self-isolation from the patients, we can see these towards the patients with TB shedding. And you can know that 28% of the doctors, they are not just unwilling to provide service, they don't even want to have this patient in the same facility with them.
Более того, подавляющее большинство врачей демонстрирует невысокий уровень знаний касательно оказания услуг по лечению туберкулеза. И наиболее высокий процент респондентов, которые оценивают свой уровень знаний как достаточный, это касается всего лишь услуги по консультированию, по формированию приверженности к лечению, в то время как непосредственно назначение лечения всего лишь 28% врачей считают свои знания достаточными, 37% считают свои знания достаточными для проведения контролированного лечения. Но является ли дефицит знаний основным барьером для внедрения амбулаторных моделей лечения? Когда докторов спросили, что если бы у вас были все необходимые знания и все необходимые навыки для того, чтобы оказывать услуги лечения туберкулеза, являлось бы для вас это стимулом внедрять эти услуги. И, как вы видите, не намного выросла мотивация докторов, и 56% докторов готовы оказывать услуги, опять-таки, по формированию приверженности, но вот назначать лечение готовы всего лишь 13%, оказывать дот-услуги всего лишь 19%. И при дополнительном опросе оказалось, что основным мотивирующим фактором для докторов первичного звена оказывается все-таки дополнительная оплата услуг. 46% высказали за то, что они готовы работать с пациентами и лечить их, если им за это будут дополнительно оплачивать. Как вы помните, я говорила, что 76% докторов готовы взаимодействовать с социальными службами. И вот здесь интересный момент, что несмотря на свою неготовность заниматься лечением, тем не менее медработники считают, что привлекать социальных работников непосредственно к выдаче медикаментов, будь то лечение туберкулеза, лечение ВИЧ-инфекции или заместительная терапия метадоном, это как бы нецелесообразная интервенция, но зато они с гораздо большим энтузиазмом готовы делегировать свои полномочия по вопросам консультирования, формирования приверженности, информирования пациентов и работы с членами семей. Таким образом, мы видим три основных барьера на пути внедрения амбулаторных моделей лечения туберкулеза. Первое – это недостаточная образованность врачей первичного звена по вопросам диагностики и лечения туберкулеза. И в данном направлении мы планируем расширять программы обучения, вводить непрерывную систему постоянного самообразования докторов, в том числе путем внедрения электронных форм, онлайн-форм обучения и использовать максимально широкие каналы коммуникации, популяризировать достоверные источники информации для самообучения медицинского персонала. В отношении стигмы мы планируем вводить широкие регулярные информационные кампании, направленные на повышение толерантности по отношению к пациентам с туберкулезом и по вопросам безопасности амбулаторного лечения. И, конечно, вопрос развития системы мотивации. Мы предполагаем все-таки найти возможные пути решения введения дополнительной мотивационной оплаты медицинским работникам за выявление случаев туберкулеза и за эффективное лечение. Спасибо, у меня на этом все.
Thank you so much, Olga, for that wonderful presentation.
Большое
It makes it clear that when you're encountering issues of decentralization, you're automatically dealing with stigma, and that it's important as we think about how to decentralize, that it's not really clinical reasons that keep people in the hospital. It's often more worries and fears. And so we're going to move quickly into our question and answer session. I want to remind everyone that after the question and answer session, we have what is probably one of our most important talks to cap a day of very exciting activities. And we'll be hearing from one of the people living with drug-resistant TB from the Zhytomyr project. There's also a side event this evening that'll take place after this finishes called the Mind Palace. And then there is a dinner this evening. So we just want everyone to be aware of these. So I'd like to open the floor for questions or comments. Again, as earlier, please state your name and your organization so that we all know who we're talking with. And I think it's a really wonderful panel to ask some questions about this idea of stigma. We talk about it all the time. We know we need to tackle it if we're going to address TB, but we very rarely specify how to do that. And I think stigma represents a lot of things. It's the attitudes of the community, it's the attitudes of providers, it's the feelings patients have towards themselves. And often these feelings manifest themselves through discriminatory behaviors. And we have to get at the roots of these. So I hope we have some interesting questions and dialogue for our clearly very qualified panel of people who are doing amazing work around this. So I see some hands. We have 1, 2, 3. And we're gonna prioritize letting people ask questions who haven't asked questions yet, and let us know which person you're addressing them to. So, and ladies, you have a microphone there, so it's
on. Добрый день.
Good afternoon, my name is Roman. I'm head of the Department for Patient Support, MSF, Minsk TB project, Belarus. Thank you very much for your work, for very useful information. And I have a question to Yelena about the statistics. The pre-training survey, you've said 94% said that adherence problem is related to alcohol abuse and this is the patient's fault. And you've said that after 3 months of trainings, this number did not change. Can you tell us, maybe you have some conclusions or ideas, what can be changed in the presentation? Because as far as I understand, you had this module aimed at alcohol problem. Maybe you have some conclusions, some tools on how to improve this, why people did not change their minds. Thank you. Thank you for your question. Of course, as I said, this is the work of the healthcare worker with a patient who abuses alcohol along with other medical problems. This issue requires being addressed and requires counseling with our psychologist colleagues. We don't have this answer because so far we haven't thought about it. We work with patients, we work on improving adherence, treatment, on achieving treatment completion by TB patients who use alcohol. How this will impact healthcare workers, we didn't think about it. We just saw this problem. We noticed it only now. That is why we're raising this problem for discussion, since it is important. I know in the country. Now we're in the middle of the health reform, which also includes mental health support. There are groups developing influence and training tools for healthcare workers at the primary level, as well as communication with difficult patients. I know about that because our co-developer of the training is member of this working group as a national expert. That's why I think maybe while preparing trainings, we need to include this component into the trainings. Thank you.
And I just want to also mention that tomorrow we're going to have an entire session devoted to talking about alcohol and substance use, where we can do a little bit of a deeper exploration of some of these issues. So I'm so sorry that I'm not following the hands, but I think we had one in the back. I'm sorry, yep, and then I see many hands. We're going to be able to take maybe 4 questions, okay? So I see 1, 2, 3, 4.
Дякую.
I would like, if possible, to have a word on behalf of the press, journalists, participants to the warfare during Maidan. We would like to thank to healthcare professionals for planet-sized dignity on behalf of Ukrainian people. We are now discussing the issue which is of global priority, and this is about saving the humanity, I would say. And the question here is as follows. Do you think this problem with TB could be resolved at the cell level, or as our scientists think it could be resolved at the genetic, molecular and submolecular level? Scientists and medical staff from Maidan times, and let me mention Anatoly Yarovoy, who has been working upon that issue. You might know him as well. Who can tell me, are we ready for a joint project, joint drafting, saying that the scope of multi-resistancy lies within molecular, not cell level, if I can say that? Do you have to say something about that? We would like to write, to publish something on that, but we would like to talk to one of the speakers today, if I may.
Yeah, so I know that many people here could answer that question, but I think it might be worth having a one-on-one conversation with many of the amazing doctors here in Ukraine to get a better answer. We're going to focus on stigma now, but I know there are people who'd be happy to answer your question later in a one-on-one session. So again, I'm so sorry, I haven't kept good track of whose hands have gone up, but maybe some of our microphone providers. We really can only take 3 more questions. So this gentleman here, I know you've had your hand up for a while.
Hello, my name is Grigor, head of mission with MSF. My question is to a colleague in Uzbekistan, as the program and using Telegram is really interesting and fascinating experience. I wonder, question 1 is if you have any idea of the demography that you're capturing, age and gender, and who uses this tool to access. And as we are speaking about stigma, do you see if there are risks that coming forward and speaking, there is a free space for people to express, even though it's on a digital platform, it can be anonymous, but have you encountered stigma also there?
Thank you for your question. Unfortunately, we're not collecting or able to collect the information that you alluded to. I think it would be much more interesting to understand our reach in terms of the region and as like you said as well, the demographics. But we're unable to do so at this point. But it may be something that we should actually look into to see if it's actually effective. In terms of if we're actually sort of addressing the stigma or actually finding stigma, not so much, but it's a lot of what people have already alluded to about what the myths are, but we're hoping, by the education and that people can at least ask the questions that they're possibly afraid to ask. Yeah, thank you.
So Dr. Hamizada from Afghanistan. So again, sorry, we're going to go 1 and then 2. We're trying to let people talk who haven't had a chance to ask questions yet. So.
Yeah, thank you. I'm Dr. Hamizada from NTP Afghanistan. To some extent, my colleague asked about the Telegram. As we know, there are more than 43 million population in Ukraine. 14% of the population is under 14, and 15% are over 65. And may it exist, they said, the age of 15 to 50, they have access to Telegram. Don't you think that the more than 30% of the population do not access to the Telegram and they will not aware about the TB? Won't it be better to have some message through TV and radios as well?
Thank you, Dr. Khan, for the question, which I think was saying
Thank
the
you.
Telegram app hits a certain demographic, and how can you supplement that with people who aren't using apps or other ways of communicating? And maybe you can start with that one, and then maybe Olga will also want to share with us some ways that she targets some of the more vulnerable populations. Thank you.
Thank you for your question. Yes, so we are already engaging with the community with a little bit of television and radio, as well as, like we mentioned, workshops, and then these sort of punctual events like World TB Day. You're right that the application is a bit limited, but it's a lot of other, just having things in print or radio is also limiting, that we're also probably only capturing certain segments of the population. It's one of the limitations, but I think it could actually have a greater reach for people who might not be available for, say, a workshop or an actual event. Yeah, thank you.
And then Olga, if you have some comments on reaching harder demographics in terms of outreach.
Currently in Ukraine, we have quite an active information campaign to raise the level of trust of public to family physicians. And family physician is positioned as the entry point and as the person who provides the most credible information to people. That is why we studied the issue related to prevalence of certain internet managers, online managers. And according to the data of our IT experts from the Center for Public Health, it appeared that the most popular messenger was Viber. But we don't use this messenger as a communication channel with the patients. We use it mostly to communicate with professional medical community. We also quite actively use Facebook, and a big amount of information is posted on this social media for general population of Ukraine.
Thank you. And I think it's a great question you brought up, Dr. Hamizada, about how do we reach these more difficult to reach populations, right? We all know that there's a big emphasis now on what people call finding the missing. And I think, again, we have to be watchful of our language there. The people are not missing, right? They're either unable or unwilling to access the services that we provide to them. So in all of our work around stigma reduction, getting people to engage with healthcare services, we have to think about novel ways of finding populations that may not engage with our usual mechanisms. So it's a great point that you brought up. So we'll go back. There's a few more questions in the audience.
Hello. So I'm Pramila from MSF Mumbai, India. So my question is to Ola. I wanted to know the rationale behind having the additional incentive to implement ambulatory care Was it because of the stigma, or is it because of the workload which the people have? So just this question.
We're switching to outpatient ambulatory treatment regimens.
We move to the outpatient care first and foremost because we want to put the biggest emphasis on the primary care. In order, for example, to reduce the risk of intra-hospital infection, it's not about the workload. We just want our patients to have the full scope of high-quality services where it's most convenient for them. And hospitals where inpatients stay, it's not the most convenient. So if I understand the question properly, this is our motivation. The outpatient model is simply a matter of time. We don't have any other choice as to implement the outpatient model. Yeah, funding. Currently, also, primary care providers, they also get paid as part of the so-called guaranteed service package. And now the matter of controlled treatment of TB is not part of the basic package of services. That is why we are now looking for additional incentive as additional bonus payment so that healthcare providers would basically be motivated to deal with these patients and to take them to effective treatment outcome. At the moment, controlled treatment of TB is still rather funded through the TB doctors silo. And it's not included in the payment of the GPs, but we want to change this and we want to put this into the primary level.
Hi, I'm Kevin, the head of mission for MSF in Kyrgyzstan. My question is about contact tracing, and stigma. So we were reflecting on this in Kyrgyzstan last year, and it became very clear that community engagement and stigma were critical issues for contact tracing. So I'm wondering, I'm not sure who to ask. I'm wondering if you can give some reflections around that.
So I don't know if anyone from our panel would like to comment on the issue around stigma and assessment of people who've been exposed to DRTB in the household.
Among the questions which we have included in pre-training and post-training assessment, we have questions that reflect rather matters of confidentiality than stigma. We want to check whether providers think it's possible to disclose the patient's status to, for example, their employers, family members, or their co-workers, and so on. That question, I think, reflects the level of stigmatization. It is there. But as for the response to how this problem can be solved, well, we thought that perhaps we also need some regulation rather than education. Well, of course we need training sessions. We need to teach confidentiality and human rights and patients' rights. And this can be also the training package for primary care providers, of course, as well.
And if I could just add some comments to that, I think the first thing around assessing individuals who've been exposed to drug-resistant or pan-susceptible TB, it's not unique to drug-resistant TB, is we have to work on disclosure counseling, right? So if you think about the field of HIV, we do pre-test counseling, we do post-test counseling, and we talk to people about how to disclose their status to their partners and other significant people in their lives. And the reason we do this is because the act of disclosure can be very risky. People may face, they may be removed from their homes, they may face physical violence. And yet if you think about it in TB for contact tracing, what do we say to people? We say, go home and tell your family you may have given them TB and they all need to come to the clinic to be assessed, right? It's not very nice. And so we have to think about preparing people to disclose, how they disclose, what kind of support we provide for them around that. And that would be an excellent place to start. So,
just to add to that, indeed stigma poses barriers to contact tracing because it is not only the institutional stigma that have been described here, like from healthcare providers, institutional stigma, as well there is community stigma, but there is as well as interpersonal and intrapersonal stigma when the person, when he is not consulted well, he is not counseled correctly, the patient poses himself, am I wrong? Something wrong with me? What did I do wrong that I got TB? And this is the usual thing we hear from patients. So they self-isolate themselves, they don't want to go to consultation, and this is posing a risk indeed. All the levels of stigma that we have seen, we experience, this is a barrier to TB care. Thanks for this question.
So we have time for 2 more quick questions. I think we have one here and then one in the back of the room. Yes, I'm sorry to point. It's very rude. My mother would be very unhappy with me, but I'm so sorry.
Спасибо. У меня вопрос.
Thank you. I have, my first question, is to Yelena. You have conducted training sessions for both doctors and nurses. So what is the result at primary level? What is the result of your work? What was the increase in the number of patients who started getting care at primary level with the GPs? The question is a little bit premature because but do you see any trend? Well, we have completed trainings in December and now we are finalizing the results and the analysis. So saying if the quality of care improved at the primary care, well, we will be able to do this, but let's wait for half a year to collect the data. Okay, so meet you in half a year. Thank you. And the second question to Vina Karir. You have conducted a very, very interesting work with this Telegram channel. My question is, if you have studied the social structures and social status of patients with whom you worked, like who they were in terms of their social status, in terms of their demographics, age group, mostly, what is the so what was the age of the patients who contacted you through the app, or maybe healthy people, and whether it was mostly men or women who used the app?
Question. Unfortunately, the statistics that we get from having the Telegram channel they're anonymous. We don't have access to any of that information. It would probably, if we wanted to understand better, we would probably have to do some sort of survey to understand not only the reach, but who these individuals are. And then maybe even adapt the messaging and the content of the channel.
Great. So we have time for one more question, all the way in the back of the room, and thank you for your patience.
Ярослав Олійник.
Yaroslav Olejnik, the problem of stigma. Is it more a problem of patients or a problem of doctors? And does this imply a change of structures?
Stigma can happen both with patients and with providers. So if I was talking about stigma among healthcare providers, but stigma among patients is another important, significant matter. Stigma emerges from the first day of diagnosis. As soon as the person hears that they have TB, they might just lock down, self-isolate, and then it takes some long support and work with this person so that they would start putting guilt upon themselves. When we work with the patients in terms of self-stigma reduction, we find that, well, it is an important component that requires attention. We need to implement this. It should be part of the efforts of NGOs and social workers, perhaps, because, well, we did conduct focus groups with people who undergo treatment in TB dispensary clinics, and there they have ideas that after the end of treatment their life is going to be different. They have this idea, this conviction. So the matter of self-stigmatization of TB patients is a very relevant thing. We need to do something about it. Thank you.
Thank you so much to Olena and Vina and Olga for the amazing work that you're doing and for spending the time with the panel to have this important discussion. I really appreciate that the Ministry of Health of Ukraine and the MSF project working here prioritized a discussion around stigma. As I said when we started this session, we love our new drugs and we love our shorter regimens, but these things alone will not solve the problem of tuberculosis. And I think what all of us know, for people living with the disease, for providers taking care of them, TB exacts a social and psychological death that is oftentimes far worse than the physical one that it puts people at risk for. And we need to think about how to stop this, not just with this very general term stigma, but by breaking down what we mean by stigma, what we mean by discrimination, and tackling that. And you women have all been heroes in doing this with providers, with people who are out in the community, and with your services here in Ukraine. So just thank you for your work and for sharing your experiences with the audience today.
Thanks to all the presenters and chairs for this very interesting discussion. Now I'm very thrilled to welcome Yaroslav Kolosovsky, who is currently being treated for TB in Zhytomyr project. Yaroslav is a preacher and is involved in the rehabilitation and counseling of people with alcohol and drug addictions and their families. We're really pleased that he's here to tell us about his experience. Thank you.
Hello, I'm happy to be able to speak in this esteemed audience. It is indeed very interesting, everything that was discussed here, and I appreciate this opportunity to share some experience. Because I was a person who faced TB directly in my life, and now I'm trying to overcome it. I first got TB in 2018, but as I had faith in God, I'm still alive, and I'm successfully completing my treatment. It has been 17 years after I turned to God and I witnessed to people that faith can change lives, regardless of the situation one faces. I used to be a criminal and a drug addict who aimlessly at the age of 22 decided just to keep injecting drugs and to die from drug abuse. But then I was condemned for my crimes and I went to prison. And in prison I heard the word of God and I found faith in Jesus Christ. And from that moment my life has changed drastically. And now for many years I serve people like me who face the issues of alcohol and drugs and other addictions in their life.
I contracted tuberculosis 2 years ago, and it started with pneumonia, which then was transformed in TB. And in severe condition, I was brought to a TB hospital. My condition was so severe that the doctors told my relatives that I might die. But thanks to care and attention of the doctors who correctly set the diagnosis, thanks to prayers of the believers, and I'm alive. It was a very hard time for me, but I managed to go through this hard period of life. And after 2 months and a half, I was discharged to outpatient treatment. I completed the treatment, but due to weak immune system, after 5 months, I had relapse. And I was diagnosed drug-resistant TB. For me, that was another psychological severe blow, and I couldn't explain to myself why it was happening in my life. And I had a good normal lifestyle, and I was taking care of other people as well. It was very hard for me to accept. And in the hospital, I spent 4 months. Now I'm finishing my treatment in the outpatient settings. During my treatment, I gained 15 kilos. I'm getting back to my activities. And I want to say that people reacted differently to my diagnosis in the place I live. And of course, this caused certain concern how I'm going to recover and how I'm going to live on. But thanks to my belief in God and understanding of my goals in life, this all helps me to recover. I continue my treatment, and I believe that I will recover completely and be useful in this world. Having gone through this path, I'd like to share some ideas which can be useful for people with TB, some thoughts. The first, it is very important to help a person to see the sense of life. Here you mentioned that, and it's very good. It's very important that a person is interested in coming back to the society, and it's important that society accepts this person. For such people like me, attention is very important. And what impressed people who were with me in the hospital, that I was visited every day. People were bringing food, they were taking care of me, and people saw that you are needed, people need you, and this is possible. I also saw patients who eagerly talked to a psychologist, and the people who help to conquer the disease, to overcome fears. Also to communicate with people and to express, to care of people who are in the inpatient settings. Maybe it's important to find out the dates of birth of the patients, maybe organize some small celebrations with a tea and cake, celebrate some holidays, Christian holidays, and use these holidays for communication, for informal interaction, so that the person in the hospital did not feel like isolated. The second thing I wanted to suggest is to organize peer-to-peer communication. And people like me who had the disease could share their experience of overcoming the disease. Maybe it would be possible to invite such people to the hospitals, to the outpatient clinics. In the whole world, there are societies like anonymous drug addicts, anonymous alcoholics. So there should be kind of a community where people, including doctors, psychologists, where all together we could overcome this issue and show people that this is temporary and one can live with that and overcome that. And in my activity, I'm more concerned not about how a person goes through rehabilitation course, but what he would do afterwards, how his relatives would accept him. And thirdly, this is more related to outpatient treatment, to help organize some regional support. For instance, in villages, if there are several patients there, maybe there could be some support community to help this person to get back to life. And today it was mentioned already, it is our attitude is really important. Someone said today that if a person was given life, we all can face various difficulties in our life, and our life may change drastically. And we need to think, what if this happens to my relative, to my friend? Does it mean I would react in the same way as people react to me? Maybe I would try to show my friend or relative my compassion and love, saying that, listen, okay, this is a hard period in your life, but you will get through. So may God help all of us to overcome this disease together. Of course, medical care is very important. We don't deny that. But another important thing is the participation of the whole society in addressing this issue. Thank you.
Very much, Yaroslav, for sharing your experiences with us. Thank you for coming. Thank you for your time. We have finished now with the presentations and panel discussions for day one of the symposium, and we were hoping to have a side event after this, but unfortunately it will not work for some technical reasons. Sorry for that. However, we still have dinner at 7 p.m. in this very hall, so you're all welcome to come here, and we'll continue our discussions here during the dinner. We have another full agenda tomorrow looking at the barriers to TB care and additional challenges such as comorbidities and alcohol use disorder. I look forward to welcoming you back tomorrow at 9 a.m. sharp here. And just a reminder, please don't forget to return your headphones at the exit. Thank you.